We'll start with the session. It's our surgery part. And in surgery, first they will ask you about this condition which is known as breast abscess. Usually, they will describe this question with a history. There is a female who is lactating her child, and now she is presenting with features of tenderness and engorgement of his breast. Tenderness and engorgement of his breast. And on evaluation, if you're able to see, when you try to mobilize this swelling, like this is the skin erythema, you will be able to see, and there is a redness. So when you try to mobilize the skin, like it is the swelling which is there, which is actually fluctuating, which is moving. So it is known as fluctuation sign positive. If the mass or if the structure is fluctuating sign positive, and along with this tenderness, with the features of fever, chillness, and engorgement of breast, all of these things, they are typical for this breast abscess. And based on the recent findings, or recently they have told that initially what you need to do, you cannot do mammography because mammography will cause compression of the breast. So instead you can do this ultrasonography, and what you can attempt is that you can attempt aspiration under ultrasonographic guidance. So what you need to do, it is aspiration under USG guidance. So you can attempt multiple attempts, or multiple times you can do this procedure, but it will be till a certain point. If you cannot feel like with these aspirations there are minimal fluids they are coming out, then you can go for INT. But the main role, it is what it is, this aspiration under USG guidance, and along with this we know there is this abscess formation, which is actually which is due to this infections of this nasopharyngeal or this mouth sacs of this child, which is transmitted from this nasopharynx to this child to this breast through this cracked nipple or something, causing this breast abscess. So just listen this, and for this you need to give the antibiotics. So you need to give antibiotics along with multiple repeated aspiration under USG guidance. If this fails, then you go for this INT. Okay, and till this swelling and things resolve, you need to do you need to drain the milk by compressing, there will be the manual compressing and manual extraction of this milk there, that you can use, but you should not feed the baby. So this is this ultrasound is showing this masses, and here we are putting up the needle, okay, where you will be able to see here, like here we are putting up the needles, and this is this ultrasound guided needle which we put, and this is this needle, and this is this ultrasound probe, and with this help we are removing the abscess part. Fine. This is the breast abscess management. Next, about this benign breast diseases. These benign breast diseases, most of them, they are classified based on their clinical feature. Mostly these benign breast diseases, they'll be having few typical features. For example, they may present to you with some of the mass. For example, in the case of fibroadenoma, it will be present to you with the feature that it will be known as breast mouse, because it will be extremely open. You try to catch it, it will be moving. So it is what it is, this fibroadenoma, also known as breast mouse. It is nothing but there is this small fatty deposition in the calcification, causing this popcorn appearance on mammography. Fine. And it is the most common benign lesion of the breast. Yeah, good Dr. Quine. Yeah, it is the popcorn calcification, and on mammography you will be able to see it. So usually if there is, unless there is any pain, or unless there is any cosmetic reasons, we won't do any surgery for it. So if there is any necessary which is causing this pain because of neuronal involvement, or if it is causing any cosmetic significance, then only we remove this fibroadenoma. So how we can remove? We can remove by enucleating it, or we can do by simple excision. Okay, simple excision, and usually we'll do this curvilinear incisions around the nipple. Okay, next one, if you see about this, few more things, this duct papilloma. Like there are few features like of the breast. See, if you see, as I told you, this is the mass. Next, what is this? This is the discharge. So there are different types of discharge, and based on the color of the discharge, so you can tell what is the thing. For example, you can see like there will be you can call them as races, because based on the color you are telling what is the disease. Fine. So in a case of duct papilloma, it will be having this bloody discharge. And remember, it is duct papilloma. We have multiple lactiferous duct. Whereas in a case of duct papilloma, mostly it will be only one duct which will be having this papillae. Means papillae are nothing but this finger-like projections. So this is this involvement of mostly only one duct. And for treatment of this duct papilloma, what we'll do, we'll remove this only one duct by this procedure which is known as microdocectomy. And then there is a thing which is known as ductectasia. In the case of ductectasia, it will be mostly this smoking and middle-aged female with a feature of greenish discharge. So this ductectasia can present even with this bloody discharge, but it is significant for this ductectasia. It is what it is, this greenish discharge. Yeah, greenish blackish discharge. Exactly, Dr. Quinen, it is this greenish and as well as blackish discharge, and sometimes it may even have this hemorrhagic and serous discharge as well. Fine. So in a case of ductectasia, it means these are the lactiferous ducts which are joining into the area of nipple. Here what will happen is this, it will be ectasic, means it will be ectasic or dilated. So for this condition where there is ductectasia, what we'll do, we'll do a surgery which is known as conical excision of all the ducts. Okay, conical excision, which is known as Hadfield's operation, which is known as Hadfield's surgery. So remember, in the case of duct papilloma, we'll just remove the affected duct. So it is known as the small one, microductectomy. Whereas in the case of ductectasia, there will be involvement of this more structure. So we'll do this surgery where conical excision of this involved duct, it is known as Hadfield operation. It is known as Hadfield operation. Okay, and there is one more condition which is seen in a case of smokers. Smokers, if there is recurrent mastitis, if there is smokers with recurrent mastitis, it will be known as Ziscar's disease. It will be known as Ziscar's disease. It is known as Ziscar's disease. Remember, it is known as Ziscar's disease. Next, we'll come into the features or this. What are the clinical presentations this carcinoma breast can have? For example, this carcinoma breast, we know it is a breast mass. Like once there is a breast mass, it will start involving this subsequent structures. Either it can go on involvement this ligament. Yeah, a good guess, ligaments, or it can go and involve the skin, or it can go and involve these other structures like our lymph nodes, and it can go enter into our blood, and it can cause metastasis. Likewise, if it's go and block this subdermal lymphatics, if it block this subdermal lymphatics, then what it will happen is that if it goes and block this subdermal lymphatics, then what will happen is that this lymphatic fluid will start collected into the breast, and this breast will be engorged. And if you see, there will be small skin pores will be there, right? So it will be like a small opening. So when it's enlarged, it looks like a peel of orange or the skin of the orange. It is known as peau d'orange. Peau d'orange appearance. Peau d'orange appearance. Fine. Next, if you see this one, this is this nipple retraction. Nipple retraction. If you see this nipple retraction, there you will be having confusion. This two things, nipple retraction, and this is this dimpling. Okay, dimpling. Okay, so this where this girls will be like the boys also will be having this dimpling, right? This dimples will be having. Okay, this is dimpling, and this nipple retraction. There's two main different mechanisms which for these two things. Like both of them, it looks like there is retraction, right? But both have a different reason. Okay, both have a different reason. See, if you see. This is a nipple. Okay, this is the anterior part of the nipple, and nipple is being connected to this lactiferous duct. Okay, nipple is being connected to this lactiferous duct. This is the nipple, and it is being connected to this lactiferous duct. Okay, and if there is any damage or if there is an involvement of this lactiferous duct, see, this is the outside which is shown as a nipple, and it is the connectivity or the continuity which is causing this, which is this lactiferous duct. And if there is an involvement of this lactiferous duct, so kya hoga? It will go and pull up this nipple. It will pull up the nipple. See, there is no nipple. The nipple is being retracted. So this is known as nipple retraction. So nipple retractions happens because of this lactiferous duct involvement. It is due to the involvement of lactiferous duct involvement. Remember, yeah, good, Dr. Anar. So next one, it is this dimpling. If you see dimpling, why it happens is, as I told you, this there is a breast, and the breast will be having this radial arrangement of this circular arrangement of this ligament. They are known as Cooper's ligament. And if there is one mass is there, and this mass causes this involvement of this ligament, then just at certain point this will bow down, it will go inside. So this will cause this one which is known as dimpling. This one is known as dimpling. Fine. And next, even it can come out and it can cause ulceration even. And in some cases, some kind of breast cancer which may show this type of, there is the nipple retraction is there. There is this swollen or enlarged breast along with this redness, and the features of inflammation. So if there is all of these features of inflammation along with this breast changes, it is seen in a case of inflammatory breast cancer. And we know inflammatory breast cancer, it is staged as T4D, whereas this peau d'orange जो भी बाहर से देखता है, तो it is staged as T4B. It is staged as T4B, whereas this inflammatory breast cancer, it is staged as T4D. इतना आपको याद रखना है, ठीक है. So in a case of this type of breast cancer, then we'll go for this further surgeries. क्या क्या कर सकते हैं? For example, if it is a very small lesion, तो हम क्या करेंगे? बस उस lesions को हम निकालेंगे, उसको बोलेंगे means there will be this simple mastectomy. ठीक है, there will be we'll removing this part, and along with this we'll remove this nipple, areola and soft tissue, and along with this breast tissue which is being affected. So it is a simple mastectomy, fine. And we'll do one more procedure which is known as radical mastectomy. If it is enough more size, yeah, if it is in a more size, then we'll do simple mastectomy along with this removal of this 1, 2, 3 nodes. Like for example, there are different types of lymph nodes, but we classify this lymph nodes of this breast based on this pectoralis minor. Okay, pectoralis minor, like below, in posterior to it and above it. So below, posterior and above it will stage them 1, 2, stage 1, stage 2, stage 3 type of lymph nodes. So if there is any more involvement, then we'll do radical mastoidectomy. So and there will be, we'll remove this pectoralis major, minor muscle as well. Okay, and followed by this we'll do one more surgery. Means because as we are removing this much structures, we need to preserve this breast for the reconstruction. Okay, in such cases what we'll do this simple mastectomy, which is the removing of nipple, areolar and soft tissue, along with this removal of 3 lymph nodes and the pectoralis fascia. We'll spare this muscles, we'll remove the fascia. Whereas we'll do one more surgery which is known as breast conservation surgery, in which there is a small mass, if it is involving just one quadrant. Okay, we'll remove that. But remember, in the case of breast conservation surgery, we'll give radiotherapy. We'll give radiotherapy to the area which we have undergone, which we have taken up. So remember, in the case of pregnancy, can you do breast conservation surgery? I guess what will be your answer? Like, yeah, we won't do breast conservation surgery in a case of pregnancy because we need to expose them to the radiation. Fine. Next, we told, like in the case of modified radical mastectomy, we need to preserve few structures. That's why we are doing this MRM. So if you see, this is this A, B, C, D. These structures will be preserved in the case of MRM. So this include axillary vein and Bell's nerve and cephalic vein and nerve to latissimus dorsi. And nerve to latissimus dorsi. Okay, so this is this axillary vein, Bell's nerve, cephalic vein and nerve to latissimus dorsi. So all of these structures will be spared or this is preserved in a case of modified okay, then the complications associated with this MRM. So what are the complications can happen? So you did a surgery. Okay, the surgery, there might be having some complications. For example, if there is while doing surgery, there will be collection of the blood, right? So while there is collection of the blood, usually it will be drained by the lymphatics. And here, while doing surgery, we may impair the lymphatic flow. So this lymphatic flow impairment lead to the formation of this collection of lymphatic fluid, which is known as seroma, serous collection. So it is not a tumor, it is the serous collection of the fluid, which is known as seroma. Take it, badhiya. Then, if there is damage to this nerve, what is the name of this nerve which is supplies the serratus anterior? If it is damage to this nerve, which causes the swinging of scapula, this is also known as nerve to bell. Yeah, serratus anterior. What is the name of this nerve? Tell me. Yeah, what is the long thoracic nerve? Yeah, badhiya Dr. Anand, badhiya Dr. Conan. So it is this long thoracic nerve. Okay, badhiya Dr. Ragul. Good. No, it is not nerve to latissimus dorsi. It is this nerve to this nerve to serratus anterior, which is known as long thoracic nerve, also known as nerve of Bell. Yeah, good Dr. Prototype, Gautam, Rahul, and Anna. Yeah, best. Fine. Next, it can result into this. As I told you, there is an impairment in this lymphatic structure. It can lead to this lymphedema as well. Okay, it will cause swelling over the hand, which is known as lymphedema, and this can lead to this necrosis. Like once we remove the part, and we'll remove around this blood supply as well, right? So superficial part, like superficial skin, they won't even get blood supply. Or if we keep some flap from somewhere else, this flap may devoid of blood supply and it can go under the necrosis. Fine. And this may lead to a peculiar complication. They will tell you there is a female after mastectomy, okay, after mastectomy, which is 10.5 years back. Okay, now presenting with reddish blue discolorization of hands and swelling of the upper limb. This is the typical case history of a lymphangiosarcoma. Yeah, 10 to 10.5 years. Yeah, it is the typical history of what? Lymphangiosarcoma. And this lymphangiosarcoma is specifically known as Shivert-Treves syndrome. It is known as Shivert-Treves syndromes. Yeah, fine. So these are the few complications that you should remember about this MRM. Okay, MRM. Fine. Next, we'll move on to this. Next, about this thyroid malignancies. If you see about this thyroid malignancies, there are different types of thyroid malignancies, and you need to know this few differences, how they are different. See, this papillary cancer, it is due to the gene mutation of BRAF. Follicular, it is due to this RAS-PTEN. Okay, iska to hame. Then medullary, we know it is due to this RET, and we only studied now. It is this MEN2A association is there. Okay, which is this RET oncogene present. Then anaplastic cancer. Okay, anaplastic cancer, it is P53. So तुम्हें इसमें क्या तुम्हें याद रखना? See, this papillary cancer and follicular cancer, they are well defined cancer because they actually origin from this proper thyroid follicles. Okay, they origin from the proper thyroid follicles. Okay, and there are few risk factors you need to know. Like papillary cancer, it occurs because of any irradiation. For example, you did a breast surgery and for this you irradiated him, okay, or her. Okay, so after this irradiation, then there is few radiations got stuck or attack this thyroid gland and are got exposed to this thyroid gland, then this can lead to this papillary carcinoma thyroid. Or in a case of hypothyroidism, we studied, right, Hashimoto thyroiditis, it can cause even this papillary cancer. Or this initially in child there will be this midline swelling which is known as thyroglossal cyst. Thyroglossal cyst. This thyroglossal cyst, if we didn't remove, this can lead to this condition which is known as papillary carcinoma thyroid. It can transfer. Okay, yeah, good. Whereas follicular, it is due to this main of multinodular goiter. Okay, in this, if you see papillary carcinoma thyroid, you want to know it is spread by the lymphatic node. See, it has the three it has this three predisposing factors. One is this irradiation, Hashimoto thyroiditis, and thyroglossal cyst. Whereas this papillary carcinoma, it spread through the lymph nodes. So the most commonly it will be having this aberrant thyroid glands. Means here is the thyroid gland, but this nodes where if you do any thyroid scintigraphy, you see here on the side of the neck as well, there is a presence of thyroid gland because it's spread by the lymphatic node. So तुम्हें पता है, it is spreading by lymphatic node. So while doing surgery, you will remove thyroid and you will also do for this modified radical neck dissection. तुम neck को भी dissect करोगे और देखोगे is there any involvement of the lymph node. So you will do thyroidectomy along with modified radical neck dissection in a case of papillary carcinoma thyroid. Okay. Whereas in a case of follicular carcinoma thyroid, follicular carcinoma में तुम क्या करोगे? Yeah, staging of cancer, if you able to read once, it's if you ask me, it is better. But if you couldn't remember it, just remember about its management only. Okay, management and simple things. For example, T4B, it is for what any of these outer changes, like for example skin erythema is there, PUD orange is there. Okay, or if there is any inside involvement, for example intercostal muscle involvement, it is what it is T4E. And if there is any involvement of this inflammatory breast cancer, it is T4D. So मोटा याद रखना, ठीक है? Don't try to indulge everything. Okay, just see superficially. Fine. And next, yeah, I was discussing about this follicular carcinoma. This follicular carcinoma, it's spread by this hematological route. So if it is spreading by this hematological route, obviously it will be spreading through the blood vessel. Okay, इतना याद रखना. So you don't need to do modified radical dissection in a case of follicular carcinoma thyroid. तो पूछेंगे, in a case of papillary carcinoma thyroid, you will do thyroidectomy along with modified neck dissection. Whereas in a case of follicular, तुम्हें modified radical neck dissection करने की जरूरत बिल्कुल नहीं है. तुम्हें बस थायराइड ग्लैंड को निकालना है, ठीक है, और डिस्टेंट मेटास्टेसिस को देखना है, ठीक है, फाइन. वैरस इन केस ऑफ मेडुलरी तुम कर सकते हो, उसमें कोई दिक्कत नहीं, क्योंकि ये दो लिम्फेटिक भी हेमाटाइटिस प्रेस भी करेगा. एंड व्हाट आर द फाइंडिंग्स यू विल सी हियर इन केस ऑफ पैपिलरी कार्सिनोमा? यू विल सी दिस टाइप ऑफ फाइंडिंग, दिस encircling findings, this calcium deposition which is known as psammoma bodies, which are actually what? These are this like concentric calcification, which is actually what? Which is this dystrophic calcification. Yeah, well play. Fine. Next, you will be able to see this type of bare nucleus or empty nucleus. It is known as what? It is known as orphan. See, this psammoma body seen in a case of papillary carcinoma thyroid. It is papillary carcinoma thyroid. Fine. Remember. Then if you see, we'll do one more investigation, which is known as FNAC. FNAC means what you will do, you will prick the needle, and with this pressure you will take up the sample, and you will just push into the slide, and you will see what are the cells in it. Whereas in the case of follicular carcinoma thyroid, I told there is an involvement of this blood vessel. So if there is involvement of the blood vessel, it should cross this thyroid capsule. So thyroid capsule को cross करने के लिए, it should invade this thyroid capsule. So you need to tell that this is follicular adenoma or follicular carcinoma only by biopsy, because there you can see this capsular invasion. Okay, like you cannot you cannot decide something based on just one phase, right? You should see both the phases. So in the case of follicular carcinoma, you cannot decide or you cannot diagnose using this FNAC. You need biopsy to differentiate between follicular carcinoma to follicular adenoma. Okay, itna yaad rakho. So as I told you, here you will see orphanine nucleus and some bodies. Okay, and here in the case of follicular, there is no use of FNAC here. Okay, so we need to do biopsy. Mostly the biopsy, it is what it is, lobectomy. After removal of this only, then we'll do the surgery. Fine. Okay, whereas medullary carcinoma we already discussed, it will be involving it's because of this parafollicular C cells. So it is because of the C cells involved. So there will be involvement of this calcitonin, and there will be involvement of this calcitonin leading to this amyloid deposition, which is this ACAL type of amyloid. Fine. And this anaplastic cancer, it mostly causes compressive symptoms. Like if you see this next one, anaplastic, it causes this mainly this compressive symptoms. It will cause this compressive symptoms. So compressive symptoms includes this esophageal symptoms, which causes the dysphagia, and if it compresses the trachea, it causes what? It causes the dyspnea. So these are the symptoms which is caused by this anaplastic cancer mainly. And as I told you, papillary, it will involve the lymph node, so it will cause, we need to do thyroidectomy. Along with that, we need to do lymph node dissection, which is this modified radical neck dissections. Whereas in the case of follicular carcinoma thyroid, it won't involve the lymph node, so we don't need to do this modified radical neck dissections. Fine. Whereas in the case of medullary carcinoma thyroid, it will spread by both lymphatic route and also hematogenous route. So in such cases, then we need to go for modified radical neck dissection. Right? And if we going for surgery in the case of medullary carcinoma thyroid, we should be ruling out to this other malignancy, because it can be associated with this MEN syndrome. Agar MEN syndrome ke saath hota hai, for example, if it is a MEN 2A syndrome, it will be associated with this adrenal pheochromocytoma. It can be associated with this adrenal pheochromocytoma. तो इसीलिए हमें सर्जरी जाने के पहले we should be ruling out this all MEN syndromes. ठीक है, बस इतना याद रखो. So in the case of anaplastic, I told you it is a compressive symptoms. So to remove it, we'll remove from here. It is the isthmus part will remove, so that it will start or it will stop compressing the trachea and esophagus. Okay, right. We'll move on to few more thyroidectomy procedures. If you see, this is the total thyroidectomy, where we are removing this entire part of this thyroid. For example, in the case of follicular carcinoma thyroid and medullary carcinoma thyroid. Fine. Whereas if in any minor pathologies, for example, in the case of multinodular goiter, if there is no tumor pathologies or carcinogenic pathologies, then we'll only leave or only cut this half part of this thyroid. But remember, with this half part, we always remove the isthmus. Okay, with this hemithyroidectomy, we'll remove always the isthmus one. Okay, remember. So it is what? It is this hemithyroidectomy. Next one, if you see, you are leaving some part of this thyroid gland which is left behind. So it is what it is known as Hartley-Dunhill procedure. Okay, so most of this gland and the isthmus will be removed, but whereas this some part of this isthmus which is near to this nerves, if we leave it, it is known as what? Hartley-Dunhill procedure. It is known as Hartley-Dunhill procedure. And the same way, if we'll do near total thyroidectomy, there are these two laryngeal nerves, which are mostly this recurrent laryngeal nerves, which will be passing nearby. So to prevent this injury to them, we'll leave on both sides. So it is known as near total. If we leave on both sides, it is known as near total. And if it is leaving more, like when compared to here, it is just around 1 gram. So if you are leaving more around 4 to 8 grams, then it is known as subtotal. If it is more than 4 to 8 grams, then it is subtotal. If it is around 1 gram on both sides, it is known as near total. Bas itna yaad rakho. This is the type of thyroidectomy you need to remember of, and these are the few thyroid malignancies you need to remember. Okay? This will move on to this thyroidectomy. So when you do this thyroidectomy, you can encounter multiple complications. So most common complication it is this hemorrhage. If you see this hemorrhage, it is mainly from this superior thyroid artery. It is mainly from this superior thyroid artery. So once you need to remove the thyroid gland, you will clamp near the gland mostly, because to prevent injury to the nerves, and also you prevent ischemia to this parathyroid gland. So you will close this. If there is a thyroid gland, you will try to ligate as early as possible, means as close as possible. Okay, remember. Okay, in such scenarios, you need to put ligature to this artery which is coming, which is this superior thyroid artery. So In some cases, in some unfortunate situations, the ligature and sty you put, it will remove and it can cause hemorrhage. And this hemorrhage, what it will do, it will go and collect in behind this suture. Okay, in the subcutaneous layer, it will go and collect, and it will, what will happen once bleeding is happening, and it will cause compressing this trachea, and it will cause neck compression and respiratory distress. Okay, so in such cases, हमें क्या करना होगा? We need to remove the suture and we need to drain the hematoma. Okay, we need to remove the suture and drain the hematoma. So to prevent this type of complications, हम क्या करेंगे usually? Once we done with this surgeries, we'll keep a negative suction drain, ताकि वो जो भी blood आएगा, we need to remove it off. We'll try to keep on removing it. So it is the one of the complications, which is the hemorrhage, and how we can prevent it. Okay. Next, if you see about this next one, this will be presented with this difficulty in respiration. So first one, as I told you, there is a formation of hematoma. This can be due to the slippage of ligature. तो तभी हम क्या करेंगे? We'll shift them to the OT. उनको OT ले जाएंगे. फिर उसके बाद we'll remove the suture and we'll remove the hematoma. Fine. Next, in some cases, as I told you, there is this recurrent laryngeal nerve. It is very, we should be very cautious. So if we injure this nerve, we know most of the muscles of this larynx will be supplied by this recurrent laryngeal nerve. So if there is any unilateral, then other side can manage. But if there is bilateral recurrent laryngeal nerve palsy, then what will happen? The only abductor of the vocal cord, which is posterior cricoid, it also go to the palsy, leading to this respiratory distress. So leading to this respiratory distress, yaad rakhna, or difficulty in respiration. Then there will be this thing which is known as laryngomalacia. Okay, what will happen is that because of this can lead to this collapsing of this trachea and larynx. And because of this, like if you ligate it, and unfortunately what you do, you injure to this parathyroid gland, and because of this calcium hemostasis has been disbalanced, and because of this what will happen is that the calcium levels in the blood will start decreasing, and it leads to this type of condition. They previously in last FMG they given this word for the first time. It is known as laryngismus and stridulus. It happens due to this complication of this thyroid surgery, which is decrease in the calcium level. So this is one of the complication which is due to this decrease in calcium. Okay, फिर उसके बाद आगे आते हैं edema to the vocal cord. You can injure that, those you can cause edema. Then as I told you, there are few more nerves which is passing nearby. One is recurrent laryngeal nerve, next one is the internal laryngeal nerve. If you injure this recurrent laryngeal nerve, the patient will be having difficulty in respiration, because the only abductor which is working, it also will be paralyzed now. Fine. Then sometimes if you injure this internal laryngeal nerve, then you will cause this paroxysmal cough. Fine. And obviously if you remove this thyroid gland, it will be having what? It will be having this hypothyroidism. तो हमें क्या करना होगा? We should supplement them with lifelong thyroxine. ठीक है, याद रखना. Yeah, good Dr. Anna. Fine. Then if we accidentally remove this parathyroid glands, then this may lead to this hypocalcemia, which is mostly seen after 2nd to 5th day after post-op surgery. Okay, after the surgery. Fine. And then we'll move on to the next topic, which is this differentiating between this indirect and direct hernia. See, remember just one word, direct hernia. See, this direct hernia, it won't pass through this deep inguinal ring. Direct hernia, it won't pass the deep ring. So iska matlab kya hai? The meaning of this is this: the direct hernia, it won't go through this deep inguinal ring. It will go through this superficial ring if possible, or else, और इसका दूसरा मतलब है, then indirect inguinal hernia, for definitely it will pass through this deep inguinal ring. ठीक है, इतना याद रखना. See, so this is the direct inguinal hernia, which is just protruding out directly. Whereas in the case of indirect inguinal hernia, तो क्या होगा? It will pass through this deep inguinal ring, and it will pass through this superficial inguinal ring as well, and it will cause this manifestation. लेकिन if you see this direct one, it will directly pass into this skin, and it can pass to the superficial one, but it won't never pass to this deep inguinal ring. और इधर ही एक triangle बनाते हैं. It is known as what? It is known as Hasselbalch's triangle. And this triangle, it is between this inferior epigastric arteries and to this rectus sheath. Okay, and this rectus sheath, and this direct inguinal hernia, it passes through this Hasselbalch's triangle, and it lies medial to it. ठीक है, Hasselbalch's triangle के through ये direct hernia जाता है, and it won't involve this deep inguinal ring. It won't pass through this deep inguinal ring. Whereas this indirect hernia, it will pass through the deep inguinal ring, and it won't pass inside this. It will pass mostly lateral to it. You see here the formation of triangle, so it will be always lateral to it. It will be always lateral to it. Okay, remember. Then they will ask you, this superficial inguinal ring, it is due to the defect in which of the following component? Okay, yeah. Then if you see this superficial inguinal ring, it will be what? It will be, they will be asking which of the following component will form the superficial and deep inguinal rings. This deep inguinal ring, it will be formed because of this fascia transversalis, whereas the superficial inguinal ring, it is due to the defect in this external oblique. This superficial inguinal ring, it is due to the defect in the external oblique, whereas this deep inguinal ring, okay, it is due to the defect in the fascia transversalis. It is due to the defect in this fascia transversalis. So these two questions they will ask you. Okay, so as I told you, the entry is of indirect inguinal hernia, it is the deep ring, and the exit, it is the superficial inguinal ring, and direct, it will be entry into the Hasselbalch's plexus. It will be entering into the Hasselbalch's plexus. Next, what are the procedures which we do for this? Yeah, we use News classifications for hernia as well. Okay, remember it. And what are the surgeries which we can do for this hernia surgeries? Okay, if you see in the case of direct hernia and indirect hernia, we do different type of surgeries. Like we can keep mesh. If you keep mesh, it is known as what? It is known as hernioplasty. It is known as hernioplasty. And if you doesn't keep mesh, okay, if you're just you can do multiple things. For example, you're just opening, and you are just opening the sac and just reducing the content, and you are coming back and suturing it. So it is known as herniotomy. And once you open the once you open and reduce it, and also you are repairing the posterior wall, and you are repairing the posterior wall, it is known as herniorrhaphy, or you try to suture it out, it is known as herniorrhaphy. Whereas in the case of hernioplasty, you reduce it and then you keep a mesh so that it won't protrude back again. So it is known as hernioplasty. So in the case of hernioplasty, what you will do, you will keep a mesh. And remember, mostly this mesh will be made up of proline, and it will be in lightweight in nature, and the pores will be large in nature, and proline or polypropylene mesh, and it will be hydrophobic. It won't absorb the water, because if there is absorption of water is there, the size of this mesh may increase and decrease, so it can decrease the tensile strength. So that's why we'll use this hydrophobic mesh. So this is the mesh. And in recent FMGE they asked where you will place, like in a case of hernia, there are multiple places you can place the mesh so that it will prevent the recurrence. See, this is the peritoneal layer. Okay, this is the peritoneal layer. If you are keeping them below it, okay, that is this keeping them below. There are three things. One is onlay, inlay, and sublay. Onlay, inlay, and sublay means onlay means above, means like just you are keeping above. Inlay means just see, you are keeping above, it is this only. And if you are keeping in between, it is known as inlay. If you are keeping in between, it is inlay. And if you are keeping below, if you are keeping the mesh below, it is sublay. So see, if any hernia need to come, if any of this hernia need to come, it need to pass this below one, then it need to pass this above one, come in between, then it will pass this above one. So wherever if you can keep, you just keep, and you will prevent the coming out of the hernia. Okay, that is the main funda. That is our main funda should be there. Okay, so if you see the first one, if you keep it below, okay, below peritoneum, it is known as sublay, which is inside the peritoneum. So it is what? Sublay intraperitoneal. But if you keep it still below this rectus sheath, but if you keep it in front of the peritoneum, it is known as sublay preperitoneal. It is known as sublay preperitoneal. Okay, then if you just keep behind this rectus abdominis, it is known as sublay retromuscular. You're just keeping behind the muscle, so it is known as sublay retromuscular. And if you are keeping in between this rectus abdominis, it is known as inlay procedure. It is known as inlay. And if you are keeping outside this, then it is known as what? Then it is known as onlay. If it is you are keeping above it, it is known as onlay. So okay, onlay, inlay, and sublay. Okay, onlay, inlay, and sublay. Just remember, fine. And they will ask you, what is the most common nerve which is being injured in a case of hernia repair? The answer is what? It is this ilioinguinal nerve, which is the most common nerve which is injured during this hernia surgeries. Fine. Next, we'll move on to this trauma scoring. Yeah, good, Dr. Anar. It is this ilioinguinal nerve. Then we'll move on to this trauma part. In a trauma part, first you need to know it is this GCS scoring. You know, it looks very simple, but on certain point you will take confusion. So remember, don't get confused with simple things and make things simple as simple, and don't get confused in it, and make sure you are getting these questions correct in your main examination. So GC score, remember it is, yeah, in the case of laparoscopy if you are doing, then it is this lateral cutaneous nerve of thigh. The patient will be complaining that he is having this radiating pain on the lateral side of this thigh. Okay, lateral side of the thigh, that is known as lateral cutaneous nerve injury, which is seen in a case of laparoscopic herniotomy. Correct, yes, correct. Then this about this GC scoring, you know, if you know this mnemonic, it is well and good. If not, just remember it is EVM. So remember it is EVM, it is 4, 5, 6. So the best one here, it is the motor. So assessing the motor response, it is the best one. So that's why given the maximum point. Fine. See, you need to know the first one. So the first one, it is always spontaneous. So if this eye opening will give 4 points. Like first, if it is spontaneous, first if the patient is opening and closing by his own, then it is E4. If he is opening to a stimuli like voice, if he is opening, you are calling him, Aapka naam kya? Means like what's your name? Then the patient is opening, then it is E3. Then you are giving this painful stimulus, then only he is opening, then it is E2. Then, but if he is not responsive, then it is E1. Okay, the minimum point, it is the 1. Okay, if it is no response, it is E1. Whereas if it is too pain while you are pinching, he is opening, then it is E2. Whereas if you are shouting, then he is answering, then it is E3. Whereas he is opening by its own self, it is E4. Next, about this verbal response. Usually when a trauma patient comes, you try to take history. When you try to take history, like based on his voice, based on his orientation itself, you can get an idea like how he is. Then he will ask you, "Aap kahan ho?" Okay, "Aap kahan par ho?" Karke means he will ask. You will start asking to him. So if he is oriented, he is telling, "Yeah, I'm in hospital, and I'm talking with a doctor." The next one, it is initially, it is what it is oriented, and you ask him where he's confused, whether he is in hospital or whether he is in the theater. So if he is confused, will give 4 points. Next, it is inappropriate responses. See, first is inappropriate words. See, inappropriate words followed by the sounds. Okay, he will tell inappropriate words whatever you ask, he will tell irrelevantly, but he will tell some words inappropriately. Okay, but if he sees like just sound he is producing, like if it is words, then it is V3. If it is just sounds, it is V2. Okay, if it is just sound, it is V2. If it is no response, it is V1. And finally, the best, it is what it is, the motor response, as I told you. So first, what you need to do is that you ask the patient to lift his hand. If he is obeying the command, it is what it is, the M6. It is the M6. And next, what you need to do, you need to pinch the hand. You need to make a painful stimuli. Okay, you make a painful stimuli. Here, see, here what he will do, means he will take a hand. Okay, he will take a hand and he will take the opposite hand and he will try to remove your hand. So he will localize the pain and he will try to remove your hand. Okay, he will try to localize it. It is the 5th point. If it will be the M5. Whereas in a case of next, for just pinching, he is unable to lift the opposite hand or other hand, he will try to withdraw. So he will try to withdraw. It is what it is, this M4. It is this M4. It is the M4. Next, remember, it is go for alphabetically. It is what? It is this flexion, then extension. It is the flexion and extension, like abnormal flexion, which is this decorticate, and then abnormal extension, it is this decerebrate. So first it will be flex, then extend. First it is what? It is flex and then extend. Fine. And next, it is what? It is no motor response. So eye opening spontaneously, 2 verbal command, and 2 pain, no response. Eye opening spontaneously, 2 verbal response, then 2 pain, then no response. Okay, fine. Then about verbal response, oriented, confused, oriented 5 points, confused 4 points, then inappropriate words 3 points, inappropriate sounds 2 points, and no response 1 point. Fine. Motor movements, he can do whatever tasks you tell. Okay, he obeys the command, it is M6. If he is localizing the pain and he is able to remove the painful stimuli, it is M5. And he is withdrawing, just he is withdrawing for the painful stimulus, it is M4. And if it is initially, if it is flexion, it is M3. If it is extension, it will be M2. If it is no response, it will be what? It will be M1. So remember this and try to answer them in the examination. Don't get confused. Okay, so based on this, we'll assess like how much is the level of brain injury. Is it a minor brain injury? Is it a moderate one? or is it a severe brain injury? So mild, moderate and severe. Okay, mild, moderate and severe. ठीक है, याद रखो. Then about this condition, okay, you saw a patient who is presenting with this tire marks on the abdomen. तो आपको लगा ठीक है इसमें तो कुछ ना कुछ तो गड़बड़ है. So there is a history of RTA which you were suspecting as a blunt trauma abdomen. So in a case of blunt trauma abdomen चलता है क्या 9 से 12. So it is what it is 9 to 12. It is the moderate one. Yeah. First investigation, it is always what it is, this ultrasound, which is this point of care ultrasound, which is the first what you will do. Okay, fine. First, in a case of abdominal trauma, see, first if any case of trauma comes, you know the like what you will do, you will put cannula, you will check for vitals. This is a usual thing. Next, what you will do, you will check for, this is an abdominal trauma case. Then you think, yeah, we need to do what? We need to do this E fast. Okay, you need to do the E fast. If E fast comes out to be negative, okay, if E fast comes out to be negative, see, for example, first why I am telling why you need to check the vitals. See, if the patient is dead, okay, and you know it is an abdominal trauma patient, and what is the role of doing is E fast in him? Is there a role? Yes, he is dead, right? So first what you will do, you will check vitals. When the patient comes, you will check vitals. That is the literally what you will do wherever you go. Okay, then you bring them. Yeah, this is abdominal trauma case. Chalo E fast karne chalte. Okay, then you will go for this E fast, and if there is in the case of E fast, if we see, you will see for this hemoperitoneum whether is there any presence of bleeding. Okay, like there are few other things also we'll see. I will discuss it later on. Okay, so if it is no bleeding, okay, if it is no bleeding, what you will do, you will just observe for him and you will repeat. Okay, you will observe for him and you will repeat it. Fine. And next, if you are able to see if there is presence of hemoperitoneum, agar hemoperitoneum mila aapko, if there is a presence of hemoperitoneum, then you need to check once again for the vitals. Are you see the reviewed vitals, like if the patient is stable or not. If the patient is stable, then you need to know like what is the source of bleeding, what is the source of bleeding which is causing this hemoperitoneum. So you need to know the source of bleeding by doing CECT, which is the investigation of choice. Whereas in a case of unstable patients, you cannot go and do for the CECT because he's striving for his life. So in such cases, you need to go for emergency laparotomy. You need to go for this emergency laparotomy. Yeah, that's correct. If the vitals are stable, then you go for CECT. If the vital is unstable, then you go for emergency laparotomy. Okay, itna aapko yaad rahna chahiye. Okay, then about this E fast and fast. Previously, like we also discussed in radiology part also as well. If you see about this fast, what we will check? Like we'll check for this heart. Okay, heart, for especially cardiac tamponade. Okay, cardiac tamponade for this blood collection. Then we'll see for this abdominal corrections. We see around this liver, like Morrison pouch. Then we'll check around the spleen to check around this splenic hemorrhages. Okay, splenic hemorrhages. Yeah, good. Splenic hemorrhages, and we check around this pouch of Douglas in females, or we'll check around this pelvic region to rule out this pelvic hematoma. Okay, pelvic hematoma. Okay, hematoma. So these are the changes we used to see in fast. Whereas in E fast, we found that there is one more condition which is causing more mortality. It is what it is, this pneumothorax. You know, pneumothorax, it is a clinical diagnosis, but in emergency situations it is difficult to delineate. So we do this E fast for this as well. So if you do this E fast, you will add right and left thorax. Left thorax. Where you will see what? Where you will see for this pneumothorax. So we'll do to see this pneumothorax. Fine. Once you found out, we'll see in subsequently hum kya karenge karke. So this is the initial and sequential role how we do. Fine. So now you do this E fast patient. Now you found out the patient is having this tension pneumothorax. Like there are two pneumothorax. One is this one is this normal pneumothorax and another one is the tension pneumothorax. Pneumothorax normally matlab we studied in medicine that pneumococcal formation seen in a case of Staphylococcus aureus pneumonia. Staphylococcus aureus pneumonia क्या करेगा? Pneumococcal बनेगा, or when sometimes this pneumococcal will rupture and cause pneumothorax. It will be very minimal. Okay, whereas in a case of during trauma, this air accumulation can, due to some of the fracture or one-way wall, this air accumulation will be on one side, and this air accumulation will be causing pushing to the opposite side. So when it causes tension to the opposite side, okay, and causing even tracheal deviation, it is known as tension pneumothorax. It is known as tension pneumothorax. और हमें पता है when there is pneumothorax, if you are able to see, there is this sign which is known as deep sulcus sign, where you will able to see this deep sulcus sign. And when you're able to keep your stethoscope on here, there will be no lung sounds. There will be no lung sounds. There will be no lung sounds because there is just filled with air. And you will try to focus. When you try to focus, then you will able to see it is because of more air. You will able to see hyper resonance during percussion. Okay, itna yaad rakho, right? In auscultation, there will be absence of breath sounds, and on percussion you will get what? You will get this hyper resonance. So there will be a presence of this deep sulcus sign. Okay, deep sulcus sign. Itna yaad rakho. So, well, mostly tension pneumothorax, it is a clinical diagnosis, but sometimes it go for till radiological investigation, okay, or we can go for the CFAST, okay. So, management based on this, yeah, hyperresonant, and based on this child or an adult, we have the management might be differ. For example, in the case of child in emergency setting, we'll put this wide bore needle at this second intercostal space in the mid clavicular line. Second intercostal space in the mid clavicular line. Whereas in the case of adults, yeah, good Dr. Anna, adults, in the case of adults, it is what? It is this fifth intercostal space at this mid axillary line. Mid axillary line, just slightly anterior to the mid axillary line. So, which is this around this triangle of safety will do. Okay. Whereas you remove the air, but still you want to check, or you want to confirm it, or you are doing as a definitive management, then you will do what? You will do this ICD insertion of this triangle of safety, which is at the level of fifth intercostal space, which is at this anterior axillary line, which is at the level of anterior axillary line. Okay, yaad rakho, anterior axillary line. Fine. And next, as I told you, like this is how this forms. Like around this, if there is a history of trauma and this kind of Ellis curve or kind of Ellis curve is there, this is because of hemothorax, because blood collection acutely. Whereas if it is just a chronic condition, just asymptomatic patients come, then it should be what? Then it should be the pleural effusion. Okay. So in the case of trauma with this features, it is the hemothorax. Okay, it is the hemothorax. Okay, which occurs due to this chest wall lacerations, and because of this hemothorax, many of the blood, it will come and enter into the lungs, so the blood volume will be less. And the treatment, it is what? It is this inserting a ICD and doing a tube thoracostomy, so that we can drain the blood. Okay, we can drain the hematoma. Fine. And next one, it is what? It is this pericardial tamponade. I'm already dekh chuke. In the case of pericardial tamponade, there is an accumulation of blood in this pericardial space, and this will show this money bag or this water bottle appearance. Okay, and it will be having this feature of Beck's triad. There will be this muffled heart sounds, hypotension, along with this increased JVP. So three classical features will be there. There will be distended neck veins, then increased JVP, and hypotension will be there, and there will be a muffled heart sounds. And treatment हम क्या करेंगे? We'll do this pericardiocentesis. We'll put a needle into this pericardium and we'll do this pericardiocentesis. Okay, and the treatment of choice, it is the surgical pericardiotomy. Okay, if it doesn't heal, we'll go surgically. Fine. Yeah, Kusumal sign we won't see. We'll see Kusumal sign in the case of constrictive pericarditis and restrictive cardiomyopathy. Fine. And next, if you see this kind of fracture where 1, 2, 3 or more than 2 rib fracture, which is continuous. Okay, which is continuous. It is what? It is the flyal chest. Okay, at 2 or more than 2 consecutive ribs at 2 or more places where they are being fractured, and because of this fracture, means when you inspire, usually the chest will come out, right? But here it will go in an opposite direction. We will call them as, yeah, so anterior or the posterior vasting. So if you see the posterior ribs, mostly it will be straight in nature, whereas this anterior rib, it will be like this. Okay, it will be coming with this having the curvature. So okay, so it is around this juncture. Okay, if you're able to see, these are this posterior rib which are actually straight, and here in anteriorly as well, here you will be able to see, right, there is a mark which is coming and joining. So this is here, there is a fracture at the level of anterior rib. Okay, here at the level of posterior rib also there is a fracture. Okay, so in the case of this type of flyal chest, what we'll do, we'll supplement with oxygen. Okay, supplement with oxygen, and we'll give analgesia. We'll less likely you do strapping of this. Okay, fine. We'll do supplementation with oxygen, and we'll give anesthesia. And in the case of failed chest which is going into this respiratory failure, तब हम क्या देंगे? Positive pressure ventilation. Like positive pressure ventilation हम देंगे. ठीक है, like BiPAP, CPAP देंगे. ठीक है? Yeah, good. Then we'll move on to this next part, which is this hypovolemic shock. Next, about this hypovolemic shock differentiation. If you see, hypovolemic shock means there is this hypovolemia, means decrease in blood volume, and decrease in blood volume, it will be because of either RTA, which is causing this hemorrhages, or fluid loss. And if there is decrease in blood loss, blood volume, then whatever is there, this blood whichever going to this left atrium will be less. So if there is less blood going to this left atrium, then there will be this this will be reflected by this, there will be decrease in PCWP, and same it will go to this circulation, and same will be received here. So there will be a decrease in JVP as well. So both of them will be decreased in a case of hypovolemic shock. Okay, but so if there is decreased volume going, obviously it will pump decreased level of blood only. So the cardiac output will be decreased. But if you see this afterload, the systemic vascular resistance means because it need to supply the vital organs, so it will produce the systemic vascular resistance. So there will be a increased systemic vascular resistance, and there will be a decreased oxygen saturation and decreased perfusion to the other organs, or most of the organs will be having decreased perfusion. क्योंकि कम ब्लड है तो कम ब्लड जाएगा. So if there is less blood and less blood only going, and it will cause only less saturation or decrease in oxygen saturation. Okay, and next if we see about this cardiogenic shock. इस कार्डियोजेनिक शॉक में क्या होता है? In the case of cardiogenic shock, there is problem at the level of heart. The heart is not pumping properly. So इसमें क्या होगा? For example, in the case of arrhythmia, fibrillations, acute MI, या valve failure, या cardiomyopathy, in pericarditis, what will happen is that there will be enough number of bloods. So खून तो ज़्यादा रहेगा, means there will be blood, but the heart is unable to pump. This preload will be there, but this heart won't be unable to pump. So if you see the pressures of this right atria and left atria, it will be more, but heart to pump nahi kar raha, so it will to the body in ratio it will be receiving less. So if you see this preload will be more, okay, it has the reserve, but it will pumping very less. So this cardiac output will be more. Okay, at the same time it will be this blood, whatever pumping less blood, it will be preserved for this vital organ. So the peripheral vascular resistance or to the skin, the blood will be very low. Fine, and because of this it will be having decreased perfusion. So हम क्या करेंगे? हम will give this dobutamine, which is an inotrope which causes more contraction of the heart. So this is the dobutamine. Next, distributed shock, also known as vasodilator shock. मतलब when in a case of neurogenic shock, there will be a decrease in systemic vascular resistance. अगर vascular resistance decrease हो गया तो then it will cause what? It will cause decreased blood supply to the vital organs. ठीक है, तो skin को ज़्यादा supply होगा और vital organs को कम supply मिलेगा. ठीक है, so whatever the blood, it lies in the periphery only. ठीक है, periphery में ही है, तो इसको कम blood आ रहा, decreased blood coming. अगर कम blood आ रहा है, then what it will do? The heart is here functioning well, so heart will try to pump very fast or very more. So it means it will pump very fastly with more blood. It will increases the cardiac output. लेकिन हमें पता है there is no systemic resistance, so whatever blood goes, it will go to this skin, and skin as a waste. So remember, it is go to the skins because the skin is having very decreased vascular resistance. तो इसी वजह से there will be perfusion mismatch होगा. ठीक है, थोड़ा बहुत जो भी मेन ऑर्गन है उनको तो perfusion बिल्कुल दिक्कत होगा. तो उसी वक्त हम क्या करेंगे? नॉरएपिनेफ्रिन या एपिनेफ्रिन देंगे. एपिनेफ्रिन देंगे because of neurogenic or septic shock. Okay, or epinephrine in the case of if there is because of anaphylaxis, the same thing will happen. Okay, and obstructive shock in a case of tension pneumothorax tamponade, like because of this outside obstruction, the heart is unable to do its work properly. So the preload तो ठीक रहेगा, लेकिन heart ठीक से pump नहीं कर पाएगा. क्यों? If you see, this heart is being filled with blood. Okay, if it is filled with blood, okay, then the heart cannot expand. It cannot go out. So as it cannot go out, it cannot accommodate more blood. So it will pump very less blood. So it is what? It will decrease this cardiac output. So systemic vascular resistance में इसमें कोई लेना देना नहीं है. So but it will try to help this body by increasing the systemic vascular resistance, and with this will the perfusion to this main organs only will be viable, whereas rest organs will be having less perfusion. ठीक है, तो इसके लिए हम क्या करेंगे? Active management. For example, if this tension pneumothorax causing this compression to the heart, तो उसको relieve करेंगे. या नहीं तो if it is this cardiac tamponade causing this collection, then pericardiocentesis करके वो खून को निकालेंगे. ठीक है, so this is the simple funda what we use for this different types of shock. How will we diagnose and how will we manage? And finally, this shock for this is this hypovolemic shock. There are different types of classifications for these shocks. This you need to remember about this hypovolemic shock. In the case of hypovolemic shock, if you see, we'll classify them based on the degree, and based on the degree classification we'll tell. If it is just small trauma, and there is a less blood loss. Yeah, less blood loss, then the blood loss will be around amounting to 15%, less than 15%. Then what will happen? The everything will goes normal. Just thoda sa, just 15%, 750 ml. Chalo chalne do. Then the BP will be normal. The pulse rate also will be normal. Whereas BP and pulse rate, everything will be normal. So you just leave them or you give them IV saline. Okay, IV saline. Okay, so IV saline and everything will be mostly normal here. Whereas in the case of stage 2, where 15 to 30% of the blood will be lost, around 1500 ml का blood lost हो गया, तो तब क्या होगा? तब there will be increase in heart rate. There will be increase in heart rate. There will be increase in heart rate, but it will be minimal. Whereas the main differentiating factor it is the start decreasing in the BP. So in stage 2 there will be a decrease in BP. Stage 2 there will be a decrease in BP. तब हमें fluids भी देना है. If हो सकता है तब we can start with blood transfusion. In stage 3 we see there is amounting to 40% of the blood loss. तो around 2000 ml 2 लीटर का blood गायब हो गया. ठीक है, और loss हो गया. In such cases the heart will pump more and it will cause proper tachycardia which is more than 120. At the same time आप देखोगे, then here the BP will be decreased and also the urine output also will be decreased because it will supply to the vital organs, it will try to skip the kidney part, so it will be decreased. Okay, so the main like brain ko blood kam ja raha, to isliye there might be confusion, so we need to replace with bloods. And in more than 2000 it is more than 40%, so there will be more tachycardia along with this decrease in BP, and there will be oliguria. There will be starting of oliguria, very low amount of urine. Okay, तब हम क्या करना चाहिए हमें? We need to do massive blood transfusion. We need to start this massive blood transfusion protocol in the case of type 4. ठीक है, इतना याद रखना. Yeah, good Dr. Anna Rajwade. Good. Yeah, BP start decreasing from the stage 2, whereas start decreasing from the stage 2, whereas pulse rate start increasing from the stage 3. Exactly, from stage 3 it causes this more significant increase. Whereas stage 4 it will be causing negligible or anuria type of features. Okay, anuria type of features. Whereas stage 3 it will cause oliguria, some oliguria extent. Whereas stage 4 it will be oliguria to anuria symptoms. Okay, that's you need to remember. Next we'll discuss about this damage control surgery. For example, you saw this RTA patient with multiple injuries. The BP start decreasing from the stage 2. BP start decreasing from the stage 2. Whereas heart rate it will be start increasing mainly from the stage 3. That's remember. Okay. This in the case of damage control surgery means the patient is having multiple injuries, but we need to act based on the need. For example, if he's having abdominal trauma, which is having this bleeding, at the same time he's having the fracture. Okay, first we need to see the abdominal trauma because it is more vital, and if there is any, if it is not being resolved, he will die soon. Okay, he will die very soon. Okay, remember. तो इसीलिए तो initial phase 1 में क्या करेंगे? तो we need to control this rapid control of hemorrhage and will prevent this contamination with further contamination. Phase 2 में क्या करेंगे? Secondary, start in stage 2. Phase 2 में आप देखोगे, then we need to do secondary resuscitation. We need to look onto this other complications. For example, if there is decreased perfusion, then the thermoregulation will be damaged. So decreased temperature, which is this hypothermia. और हमें पता है when there is this hypothermia, it may lead to this coagulopathy and it may form this clots and it can even lead to this metabolic acidosis. So second में we need to take care of this 3 things: hypothermia, coagulopathy and metabolic acidosis. In third, we need to do definitive surgeries. We need to do definitive surgeries like planned re-exploration and stroma formation. Like for example, if this abdominal trauma, we need to do re-exploration, we need to correct the defect and we need to put stroma as temporarily. फिर उसके बाद जो भी है बाद में देखेंगे. So it is the phases, phase 1, phase 2, phase 3. So initially explore करेंगे, फिर secondary resuscitation करेंगे, फिर उसके बाद main, फिर उसके बाद क्या करेंगे, फिर definitive surgery करेंगे, फिर definitive surgery करेंगे. ठीक है, इतना याद रखो. Next about the stages. First, you need to know to whom it is select. You cannot just go and select. It is a head trauma patient. There is no way related to this. So, who is having just single injury, you cannot go for damage control surgery. So, you should select the optimal patient. Then you should bring them to this OT and you need to control the hemorrhage. That is the phase 1, which is seen in a case of which is done in a case of stage 2. Whereas in stage 3, we did ICU resuscitation, which is the phase 2. And finally, we'll do this definitive surgery for this, and followed by this, we'll close the abdomen in the 4th stage of this damage control surgeries. There are 3 phases and 4 stages. Don't confuse it. Or sorry, 5 stages. 3 phases and 5 stages. Don't confuse it. Fine. Then we have this protocol which is known as massive blood transfusion protocol. this massive blood transfusion protocol, if you see, when we'll call if there is any replacement of entire blood volume in 24 hours or replacement of more than 50% of this total blood volume within 3 hours, or transfusion of more than 4 units of PRBC within 1 hour, or if there is any ongoing bleeding, or if there is we are transfusing more than 10 units of PRBC within 24 hours, or 4 units within 1 hour, or 10 units within 24 hours, we'll call them as massive blood transfusion. Our massive blood transfusion will take up in the ratio of 1:1:1 PRBC, FFP and platelets. PRBC, FFP and platelets. Fine. And you need to know this few scores. This SARS score. Okay, fine. This SARS for this systemic inflammatory response syndrome score. This score which is used to differentiate from this means usual sepsis and the inflammation part. Fine. So in this, you need to know 3 things. Okay, like 4 things especially. Temperature, it will be either it can be less than 36 degrees or it can be more than 38 degrees. Okay, and the respiratory rate will be more than 22. The components which you know, it is the temperature, respiratory rate, heart rate which is more than 90 beats per minute, and WBC either less than 4,000 or more than 12,000. Okay, so itna yaad rakho. Then Q SAFA, you know, it is the GB road. It is the GB road. You can remember as GB road. So GB means it is the gas close coma scale, and then followed by this systolic BP, which is the systolic BP, and systolic BP less than 100, and respiratory rate more than 20 per minute. Respiratory rate more than 20 minutes. So these are the components for this Q SAFA. Fine. Next, we'll see some more scores. For example, our MELD score. Just you need to remember about these components, like where we'll use and what are the components. If you see about this MELD score, it is used for this model for this end stage liver disease. So in a case of liver transplantation, we'll use this MELD score. And if you see what are the components we'll use this bilirubin, we'll use this INR and serum creatinine. So we use the CBI one here also. So it is the creatinine, bilirubin and INR. Along with this, we can use the sodium as well. So remember, it is used for this assessing the mortality. Okay, so who are having this higher MELD score, there will be higher mortality chances. Fine. Next, about this PERLD score, would be having this, will be remembered as BIAS. Okay, BIAS. Okay, so there will be this bilirubin, INR will be there, serum albumin will be there, then age will be there. Okay, age will be there, and there are some other parameters. So remember it mainly as BIAS. So remember it is bilirubin, INR and albumin. Bilirubin, INR like PT-INR and albumin. Whereas in Nessel's index, we'll use this bilirubin, INR and SGOT. Okay, bilirubin, INR and SGOT. Here also the same bilirubin, INR, albumin, ascites and asterisk. In a case of Child-Pugh score, and in discrimination score, we'll mostly use this 2 parameter, which is this bilirubin and PT-INR. Okay, just write in your table. Okay, because in just I guess 2 years back they asked this Q SAFA. What are the components of this Q SAFA? GCS changes less than 14, respiratory rate more than 20, and systolic blood pressure less than 100 or less than 90. Like this they will ask. Or which of the following is not a component? Like respiratory rate, systolic BP, diastolic BP, are mental changes as gas close coma scale. Remember, yeah. Okay. So these are the things you need to remember about this important scores. And finally, if you can, then remember about this asepsis score, about this wound healing. So if you see, once you suture a wound, you need to know whether this is healing properly or not. This is healing up properly or not. So, or you need any additional interventions to maintain this normal aseptic precautions or to promote this normal healing. So this include initially A for additional treatments like antibiotics or drainage of the pus if any presence or debridement of the wound. And then if there is any serous discharge, erythema is there, purulent exudate are there, or is there any separation of this deep tissues inside this suture you closed it, or is there any isolation of the bacteria which is present near the wound site. Means if there is any bacterial infections, then it will prevent this wound healing, right? Then how much is the hospital stay? So based on it, we'll collect this score which is known as asepsis score. Okay, it will be bit hard to remember this, but make sure you are just having idea. Means if you having idea, this scores can be asked. Fine. Then we'll what's the time now? Yeah, we'll do this one more part about this urinary system and we'll conclude it. Okay, then GIT will do after the break. Fine. So if you see about this urinary stones, we already studied about these crystals. We saw this dumbbell shaped crystals will be seen in a case of calcium oxalate monohydrate, whereas this envelope shaped crystals, it will be seen in a case of calcium oxalate dihydrate. Then this Coffin lid crystals will be seen in a case of triphosphate stone, also known as struvite stones, and rhomboid shaped crystals will be seen in a case of uric acid crystals. So we know these crystals, and in these crystals it can cause hyper or supersaturation, which is leading to this formation of urinary stones. And for this urinary stones, we know up to 5 centimeter, up to 5 millimeter, we won't do any intervention. We'll do conservative management. What we'll tell, if it is still 4 centimeter, per 4 millimeter, per 1 mm, we'll add 1 liter of water extra. So if it is 4 millimeter, we'll tell them to drink 4 liter of water a day. So if you drink more water, it will come, there will be diuresis will be happening, and it will come by this urinary pathway. Right? So if it is more than 5, then we'll go for the intervention. What we can do is that we can do one thing which is known as extracorporeal sharp wave lithotripsy. What will give? Will give a shock wave from the outside. When you give this shock wave, it will go and break these stones into small pieces. Will go and break stones into small pieces, and will come out through urine. So remember, this ESW will be contraindicated in the case of pregnancy and any bleeding disorder. Okay, remember, and any bleeding disorder. Next one, it is the PCNL. So if some stone is very big and it is very hard, then we'll do this percutaneously. We'll go mostly around this posterior, the lateral aspect. Then we'll go and remove the stone and we'll put up a tube. Next one, if this stone lies on this inferior part of this ureter, then we'll go ureteroscopically. We'll go by this scope, and we can go on, take up the stone, and we can come back. Okay, we can take up the stone and we can come back. So it is what it is, this URS. Then okay, so mostly, as I told you, we need to give them additional fluids like 4 to 6 liters per day, and it will easily wash out the stones. Okay, so this is it. Yeah, if it is more than 2 centimeter, we'll try to use PCNL. Remember, yeah, good. Then some other methods, like for example, acidification and alkalinization, and we'll try to avoid this loop diuretics because loop loses calcium, whereas in a case of renal stones who is having hypertension or who need this diuretic support, will try to use thiazides. Will avoid loop diuretics because loop causes losing of this calcium into the urine. Okay, itna yaad rakho. Next, if you see about this TB of the urinary system, it will be spread secondarily from hematogenous route. Like hematogenous, by blood it will come here. Okay, usually it will be from the lungs, which is having this primary foci, which is being spread into the kidney. So this will be having this multiple features. One, it can cause this type of calluses, which is known as moth-eaten calluses. Okay, then it can cause this type of formation of pus inside the kidney, which is known as putty kidney. It causes this type of kidney, which is known as putty kidney, which causes this pus formation. Then this putty kidney can undergo what? Yeah, good, Dr. Parul. This putty kidney can undergo calcification, which is known as what? Which is known as cement kidney. Cement kidney, fine. And this tuberculosis, it causes this scarring of this bladder, and it causes this very small. This bladder will become very small, which is known as what? Which is known as thimble bladder. Thimble bladder. Okay. And one of the earliest finding, if you see, means you do this ureteroscopy, while the earliest finding you will see, it is the pallor around this ureteric orifice. Where the ureter comes and joins, you will be able to see this pallor, and on later part you will be able to see this type of ureteric orifice, which is known as golf hole ureteric orifice. So it is asked in NEET PG examination, where you will see this golf hole ureteric orifice. It is seen in a case of TB. It is seen in a case of TB. Okay. Then about this, it can go ahead and it can involve this prostate, and means like it can come via the prostate. Mostly it will spaz it, and it will cause this infections over this vas deferens, and in vas deferens it will cause this beaded appearance. And it will cause this beaded appearance. Okay, and the investigation of choice for this TB, it is what? It is this IVP. We'll do this intravenous pyelography, and earliest sign, it is this sign, which is known as moth-eaten calyx. Fine. For treatment, what we'll do, we'll give ATT and we'll manage the complications. For example, if there is thimble bladder, then we'll augment this bladder. Fine. If there is any ureter changes, then we'll do it. And if there is any putty kidney, cement kidney, we'll analyze the level, or we'll analyze its function, and based on it, we'll remove or we'll keep it. Fine. And next, about this urinary bladder carcinoma management. So they started asking about this urinary bladder carcinoma management. So you just see, remember, this is the urinary bladder. So initial stage of this urinary bladder cancer, we can use few chemotherapy agents. One of them is BCG. So we discussed yesterday in PSM that all of the vaccines, they are what? They are this primary level of prevention, except using BCG vaccine in a case of CA bladder. So in a case of CA bladder, if you use BCG vaccine, it is considered as a treatment modality and it will come under this secondary prevention. It will come under this secondary prevention, not this primary prevention. Yeah, good, Dr. Gautam. Good. Yeah. Medullary sponge kidney, it will be in a different manner. Like there will be arrangement of this radial arrangement of cysts will be there in the case of medullary kidneys. They will tell at like a kind of brush appearance. Okay, that is a different entity, Dr. Koinen. Okay. See, so in a case of initial, he will go inside the bladder and he will give intravesical chemotherapy, and followed by this, what he will do, if there is a small and single lesion, he will go by this transurethral route and he will remove it. Mostly it will be if it is small and single one, it is the papillary tumor, and if it is multiple, he will go for this TUR resection and also he will go for this chemotherapy. He will resect and will give chemotherapy. For T1, we also do the same, TUR plus intravesical chemotherapy. For after T2 to T4 stages, what we will do, we will remove the bladder. We'll do radical cystectomy followed by adjuvant chemotherapy and radiotherapy. Okay, followed by adjuvant chemotherapy and radiotherapy. So the same thing will be repeated from stage T2 to T4. So they will be asking this is having a large mass which is being spread to the nearby locations, means it will be stages more than T2. So if it is stages T2, T3, T4, then it is what? Then it is an advanced stages. In such cases, we need to remove the bladder, and along with this, we need to give radiotherapy and neoadjuvant chemotherapy. Remember, okay? Neoadjuvant chemotherapy. Fine. Then, so what are the agents we'll use? I told you one of them, it is the BCG and mitomycin C will use. BCG will use, mitomycin C will use. It can be remembered as MET BCG. So mitomycin C, epirubicin, thiotepa and BCG. Fine. And next, systemic chemotherapy by IV route, means two routes we can give. Like we can give just transurethral will go and will deposit, will flush here. So it is what? It is intravesicular. But some things we can give by intravenous route. What are they? They are this MVAC regime known as methotrexate, vincristine, adriamycin and cisplatin. So read this thing, because see, the smoking causes lung cancer. It is acceptable. But this tobacco usage causes bladder cancer. And smoking and tobacco usage causes bladder cancer. That's why there's an increase in prevalence of this bladder cancer. That's why they are asking this bladder cancer question. So just remember. Fine. So just remember about this bladder part. Fine. And about this testicular torsion, the mostly it will be seen in this children or young individual, where you will be able to see this deformity. Mostly if you see, this is the testis and this is this tunica vaginalis. Usually it will be attached to this like this. Whereas if there is high infestation of this tunica vaginalis, the testis will be supportless. So because of this supportless testis, what will happen? It will go and roam around. It will go on torse itself. So it is known as testicular torsion. It is known as testicular torsion. So one of the risk factors for this, it is what it is, this high infestation of this tunica vaginalis, which this known as bell clapper's deformity. You know, right? In mandir, in temples, there will be a bell. Okay, this is bell. Yeah, there will be a bell, right? So bell will be there. So here like that, here there will be tunica vaginalis. Here will be testis. So it will be swinging like this. It will be swinging like this. So it can undergo torsion. So this is what? This is this testicular torsion. Fine. And this will be featuring with the presence of agonizing pain along with the features of nausea, vomiting. There will be a pain, nausea and vomiting. Pain, nausea and vomiting. And remember, this can involve both the testes. This can involve both the testes. And how will you differentiate it? What you will do? First you will do a sign which is known as friend sign. What you will do? You will lift the testes of the patient. Once you lift the testes of the patient, if the pain relieves, then it is not testicular torsion. It is acute epididymoarthritis. If this lifting the testis, if his pain relieves, it is what it is, this acute epididymoarthritis. Whereas if you still lift the testis, but he is still feeling the pain, so it is what it is, the testicular torsion. If he is still feeling the pain, it is the testicular torsion. And in the case of testicular torsion, you need to check for the vascularity. Once the vascularity is there, just compromised, then you will do surgery. And in surgery, you will be able to see this testis which is being affected, it will be high reading. So this sign which is known as angel and demon sign. This is known as angel and demon sign. Okay. An examination, the affected testis will be high reading. It is known as angel sign, like high reading, which is called demon sign, and there is thing which is known as, means demon is there and angel is there. So two signs will be there. So contralateral normal testis will be angel. So contralateral which is normal, this an angel. So remember. Yeah, good. In the case of friend sign is will be negative in a case of testicular torsion, and ensign will be positive in a case of acute epididymoarthritis. Okay, and here if you elicit the chemistry reflex, it will be absent. Okay, and investigation of choice, we need to see this vascular supply, will do Doppler, fine. And here management will do emergency orchidopexy, fine. And next it is the gangrene. This type of gangrene which is occurring at the level of total regia, which is known as what? Which is known as corneous gangrene. And this is what? This is the necrotizing of this fascia. It is this necrotizing fasciitis. So it is this necrosis of this fascia, superficial fascia especially, superficial and deep fascia, both of them, and it will be caused by both aerobes and anaerobic organisms. And for this, we'll do debridement and antibiotic covering. Fine. And this nephrectomy, where I will do this nephrectomy surgeries, like especially this partial nephrectomy. Like if there is a RCC, but still you just want to remove the tumor part, you will leave the kidney part. Like if there is any size of tumor, if it is just up to 4 centimeter, then what we'll do partial nephrectomy. And if it is just a RCC in only one kidney was there, and in one kidney only there is RCC is there, then we'll do partial nephrectomy. And if there is involvement of both kidney in RCC, then we'll do partial nephrectomy, or RCC with already deceased kidney. Okay, one kidney is already deceased but it is having RCC, so here we'll do partial nephrectomy. Fine. And finally, the paraneoplastic syndromes of RCC, the most common one, it is the increase in ESR, and it can also cause increase in calcium levels, and this RCC can cause liver damage. Yesterday in pathology also we studied this RCC induced liver damage because of this interleukin 6. Because of this interleukin 6, it is known as Stuffer syndrome. And this RCC can go into the lungs. Okay, metastasis into the lungs, and can cause a metastasis like a cannonballs. It is known as what? It is known as cannonball metastasis. It will be caused by both RCC and choriocarcinoma. Okay, choriocarcinoma. So guys, so that's it about this urinary tract part. Okay, we'll meet up with this GI part. We'll start after this break. Fine. It is 2:22. We'll take our break till 3:05. Okay, till 3:05 p.m. will resume. Okay, and mostly it will be taking around next 30 minutes to complete the surgery. Then we'll start up with this gynecology part, which is also a high yielding one. And gynecology part will maximum take around 1 hour 30 minutes to 1 hour 40 minutes. And this is our ideal timing, and we'll usually finish with our usual timing ones. Fine. If any things are doubts, please let me know. I'll help you out with it. Fine. Then we'll start with our thing. We'll start with this GAT part. The first one, it is what? It is this achalasia cardia. If you see the first one, it is this achalasia cardia. This achalasia cardia, it is actually what? It is due to this absence of this relaxation. We studied in physiology, there is no VIP which causes relaxation. Means nitrous oxide and vasoactive intestinal peptide, both of them, what they do, they causes relaxation of the sphincters. So whereas in the case of achalasia cardia, this lower sphincter is not being relaxed. So because of this, what will happen is that there will be constriction. There will be constriction at the level of lower esophageal sphincter, and this leading to this dysphagia. And this dysphagia is frequently, it is most commonly for liquids than solids, because if there is solid component goes, it will stimulate and irritate this nearby nerve plexus, and it will cause this opening of this lower esophageal sphincter. Whereas liquid, how much ever you fill, it won't create this pressure to this threshold level, so that this LEH won't open it. Yeah, good, Dr. Annar. It is what it will produce this type of thing, which is known as what? Bird beak appearance and barium swallow. It produces this bird beak appearance and barium swallow, and also which it is known as, because of this tapering, it will call them as pencil tip appearance. Okay, pencil tip appearance, and sometimes will be used as a rat tail appearance as well. Okay, but this rat tail we often confuse with this carcinoma esophagus, so we less often prefer to use it. Fine. And the investigation of choice, it is the manometry. In manometry, if you are able to see here, this relaxation pressure, it will be more than 55 millimeter of Hg, along with this presence of failed peristalsis. Means there will be no peristalsis, and along with this pressure is more. So because of this increased pressure, there's less lower esophageal sphincter, it won't open. Okay, so as this won't open, this leads to this achalasia cardia. Right? This leads to the achalasia cardia. So what we need to do is that We need to open it by breaking the contraction. We know calcium causes this muscular contraction. So we'll give this calcium channel blockers, and we know this, we told no VIP like nitrous oxide and vasoactive internal peptide will cause this relaxation of muscles and sphincters. So we'll produce this nitric oxide by the help of nitrates. Or in as a surgical modality, what we can do is that we can go and cut this muscles over the lower esophageal sphincter. It is known as Hernias cardiomyotomy. It is known as Hernias cardiomyotomy as endoscopically or laparoscopically, or else we can go even by the help of peroral. Means in the oral route only we'll go and we'll create a small opening in this layer of esophagus, and we'll go to the muscular layer. Okay, there will be this layers, mucosa, submucosa and muscular layer, and we'll go to this muscular layer and we'll cause incision and will cut this layer. Fine. So it is known as what? It is known as poem. So perorally, by oral route we are going with endoscopic help and we are cutting this muscular layer. So remember, so it is the treatment of choice is what? It is the Hernias myotomy, and now recently we are using the poem part. Fine. And this is the manometry I told, and this is the Variance fellow, so showing this bird beak appearance. And next we see few more motility disorders. One is this nutcracker's esophagus. Next one, it is this diffuse esophageal spasm. There is small lineage differentiate between these two. If we see about this diffuse esophageal spasm, what is alacrimia means? Where it is actually alacrimia means absence of tears. Ashutosh Jha plus try to correlate with this topic which we are teaching. Fine. And if you have any doubts related to it, we will post in the middle. If not, just keep it with you. We'll answer it in the end of the session. Fine. And then if you see this diffuse esophageal spasm, it will be there will be having this diffuse esophageal spasm, and it will cause this corkscrew shaped esophagus. It will show this corkscrew shaped esophagus. Fine. And it is due to this impairment. And this, because of the spasms, it causes this impairment in this vascular supply. And it is actually due to this tertiary contractions. Means usually there will be this peristalsis, whereas here there will be this tertiary contractions which are actually spasmodic. And because of this spasm, the vessels will undergo spasm, and it will cause what? It will cause compromise in the vascular supply. And if there is any compromise in the vascular supply, it leads to the ischemia. Especially it will mimic, because of this ischemia, it will mimic the myocardial infarction, especially on the left side. Fine. And it will be always associated with this dysphagia. Here also we'll use this manometry to measure the pressure. Here the DCI will be more than 400. It will be more than 400. Okay. Then the management here the same. The muscle is contracting, so we'll remove the muscle contraction by blocking the calcium channels. So we'll use calcium channels, and it will make the open this esophagus by giving the nitrates. Fine. And okay, and in later part surgically what we can do is that instead here, means in the case of achalasia cardia, we did this small myotomy, whereas here we'll do long myotomy. Fine. And nutcracker's esophagus, it is the most common motility disorders. Okay, it is most common painful hypermotility disorder, and this nutcracker's esophagus, it's almost similar to diffuse esophageal spasm. Whereas this nutcracker's esophagus, the pain or this DCI will be more, which is very much more, like around more than 800 when compared to this compared to this diffuse esophageal spasm, which is more than 400. So the DCI here, it will be more than 800. So this is, just remember. Okay. And both of them will be having this dysphagia. Next, about the CA esophagus. Usually the CA esophagus patients, he or she also complains with the features of dysphagia. Once they complains about the features of dysphagia, okay, then what will happen? Because of this dysphagia, yeah, good Dr. Anil Rajpati. Because if you see, there will be this mass, and this will allow to pass this liquids, whereas solid, if it comes, it will come and get stagnant over here. Okay, it will come and get stagnant over here. So that's why it causes dysphagia to, especially to the solids, but actually it will cause dysphagia to both, but more common to the solids. Okay, and there will be, because of this dysphagia, there will be a features of weight loss, and in later part, this esophagus may get in connection with this trachea and can cause tracheoesophageal fistula. Remember this. And for this, we can do few procedures. For example, we can remove this esophagus where there is a presence of cancer. You know, the most common cause of esophageal cancer, it is a squamous cell cancer, and it is mostly at the midline. Whereas if it occurs at the inferior part, it will be the adenocarcinoma. So wherever there is a esophageal cancer, we need to take 10 centimeter margin. Means if there is cancer here, we need to go around and cut around 10 centimeters. Okay, we need to take this 10 centimeter margin. Just remember this. So for this esophageal cancer, we can do few surgeries like Ever-Lewis operation, Orient transhiatal esophagectomy, which is more commonly done, and Mekion en bloc esophagectomy. So all of this procedure are done to remove this esophagus, and after this we'll catch up the stomach as a conduit, or we'll take from the small intestine as a conduit, and we form a alignment with this oral cavity, or with this cricopharynx we'll have this alignment. Fine. And in few cases where this tracheoesophageal fistula is there and in advanced stages, we'll provide some stents, like we'll keep some stents and we'll just give them relief by providing the stents, and it will provide relief from the dysphagia component. Fine. And next, for this we can use some of this chemotherapy regimens, which includes epirubicin, cisplatin and 5-fluorouracil. So epirubicin, cisplatin and 5-fluorouracil. Epirubicin, cisplatin and 5-fluorouracil. Fine. Then we'll move on to the next part. You saw this child. You saw this child or this infant who is just 3 weeks old. Okay, this child is 3 weeks old and he is presenting with, the mother is bringing her with this features of projectile vomiting and multiple episodes of vomiting. On evaluation, you will be able to see there is this presence of this olive shaped mass. Olive shaped mass. And the child is very much dehydrated. And now, if you are able to do this analysis, you will be able to see on X-ray, you will be able to see this single bubble appearance. You will be able to see this single bubble appearance, and all of this following. Yeah, they are 21 days old, or this child with the age of 3 to 4 weeks, along with these features of projectile vomiting and with multiple episodes and a olive shaped mass, we will be suggestive of hypertrophic infantile pyloric stenosis. It will be suggestive of, it will be non-bilious vomiting. Correct, guys. So it is what? It is this infantile hypertrophic pyloric stenosis. And we know there are different shapes of muscle. There will be this circular muscles and there is this longitudinal muscle. So see, in the case of infantile hypertrophic pyloric stenosis, it is the circular muscle which is being hypertrophied. Yeah, previously it is known as CHPS. Now it is known as infantile hypertrophic pyloric stenosis. Fine. And there will be multiple episodes, and because of this vomiting, there will be loss of this, and because of this, what will happen is that there will be this loss of this ions which is in the acidic component. So it will lead to this hypokalemic, hypochloremic, metabolic alkalosis. But instead of this metabolic alkalosis, instead of maintaining, the kidney will reach out, or kidney will send more acids to the outer side to save this kalemia component, which is this potassium component. So it is known as what? Hypokalemic, hypochloremic, metabolic alkalosis with paradoxical aciduria. Fine. And for the treatment, I told it is a dehydration. So we need to treat the dehydration component, which is this normal saline. Next, for treatment of choice, we'll use Ramstead pyeloplasty. We'll do this Ramstead pyeloplasty. Just remember. Fine. Yeah, it is due to the inner circular. Yeah, guys, that's it. Then we'll move on to this gastric ulcer. In gastric and duodenal ulcer, you need to know about the complications. There are a few complications which may include. It may cause eroder to the arteries, and it may cause bleeding over it. Okay, it may cause bleeding. And second is, it can also erode and it can cause perforation over these regions. So it can cause perforation and also bleeding. Okay, so it can cause perforation and bleeding. Fine. So if there is any complications like bleeding, the most common complication is of this peptic ulcer, it is the bleeding one. Okay, whereas perforation, it is the most common for this gastric ulcer. Okay, perforation is the most common complication which is most commonly seen in a case of gastric ulcer. And there is one more complication which is known as gastric outlet obstruction. Means because of this ulcer, there will be what? There will be this scarring, and because of this scarring, the stomach may turn and it can cause gastric outlet obstruction. And see, if there is bleeding, we need to know which artery is bleeding so that we can control. For example, in the case of juvenile nasopharyngeal angiofibroma, we know the artery which is responsible, it is what? It is this sphenopalatine artery. Likewise, if you see here, this duodenal artery, the most commonly involved artery for bleeding in duodenal ulcer, it is what? Is the gastroduodenal artery. So in a case of bleeding from this duodenal ulcer, we need to go and ligate, or we need to repair around this gastroduodenal artery. So just mostly this artery will be lying behind this duodenum. So that's why it is seen in case of posterior ulcer perforations, whereas anteriorly it will lead to this perforation, whereas posteriorly it leads to this bleeding as a complication. Okay, fine. And this, for this treatment of this bleeding duodenal ulcer, what we can do is that we'll ligate the bleeding vessel, And what else we can do is that we can do truncal valvotomy, okay, because there is increased acid secretion because of this PEG supply. If you cut out this supply, then there will be no acid secretion. So we can do truncal vagotomy to prevent recurrence, and we can do this pyeloplasty to prevent the stricture. So this is in the case of bleeding. Whereas if there is any perforation, in the case of perforation, what we can do is that if there is any here perforation, we can bring the nearby momentum to this place and we can suture them out with this perforation. How if there is a tire punctures, then we are bringing out something when we are keeping as a patch. So likewise here using this omental patch repair. अगर हम omental patch repair हम use कर रहे हैं तो इसको बोले कि हम Graham's repair. It is known as Graham's repair. Okay, just remember it is known as Graham's repair. और इसमें हम vascularized pedicule of momentum use करेंगे. Means it should be viable because once it starts healing, you know that this healing it need to be continuous. अगर ये भी necrose हो गया तो दोबारा perforate होने के chances ज़्यादा है. तो इसीलिए it should be having a viable and its own blood supply. इतना याद रखो. A good Dr. Anar. Fine. Then we'll move on to this type of gastrectomy. This type of gastrectomy include this first one, which is this gastroduodenostomy, which is this Billroth one. Whereas in a case of Billroth 2, you see this gastrectomy and followed by which there is this gastrojejenostomy. There is this gastrojejenostomy. And next, if you see, there are a few more gastrectomy. If you see, this is known as RU-NY. So what we'll do is there are two ruminants. So mostly this is done as a case of either in a case of restriction from the food intake or because of some complications of this ulcer. Fine. So what we can do is that usually this esophagus connected to this gastric pouch. Then what we'll do, we'll cut out at the level of jejunum. So what we can do is that one jejunum, we have this two jejunum, this end and this end. So what we'll do, we'll bring this jejunum to here. Once we bring this jejunum to here, we'll attach to this to this small part. So it is what is this gastrojejenostomy. And the leftover part of the jejunum will take this jejunum and will go and connect with this one more jejunum. So it is what? It is this gastrojejenostomy and jejunojejenostomy. And it will be forming this type of Y limb. It is known as RU-NY limb. Okay. And one of the complications of this gastrectomy, it is dumping syndrome. Okay. There will be two dumping syndrome, early dumping syndrome, late dumping syndrome. And there will be this phenomena over this limbs. Okay. Just remember. And as a bariatric surgery or to reduce the weight or to decrease the secretions, what we can do is that we can remove some part of the stomach like a sleeve. So okay, we'll pass the stapler and we'll cut and remove it. So it is known as what? It is known as sleeve gastrectomy. Okay, yeah, yearly and late. Yeah, yearly it will occur in a few minutes and late it will occur after a few hours. Okay, just remember. And next they will give this X-ray image and they will ask you which of the following is this? Is this a small bowel obstruction or large bowel obstruction? See, first to differentiate small bowel and large bowel obstruction, you need to know what is the useful or what is the initial clinical findings. If you see in a case of small bowel obstruction, if you see, mostly it will be presenting with features of vomiting, abdominal pain, and along with this gauding and rigidity. Whereas in a case of large bowel obstruction, it will be presenting with constipation or obstipation. Yeah, good Dr. Anar. Obstipation. So it will be having this constipation or obstipation or complete loss of, there will be no motion will be passing and there will be no gas which will be passed here. So it is known as constipation or obstipation. Okay, along with this pain and gauding and rigidity. Fine, this will be seen in a case of obstruction. Then followed by which we need to diagnose like whether this is small bowel or large bowel. If you see in a case of small bowel obstruction, it will be mostly placed central. Okay, it will be mostly placed centrally. Whereas if you see about this large bowel obstruction, the bowel loops mostly lie in the peripheral part. It will lie in the peripheral part. Okay, so in a case of small bowel, it will be center. See, remember F for S, it will be in central. Yeah, good. In a case of small bowel, especially in a case of jejunum, they will be having this valvulae conventis. It is known as valvulae conventis, which will be having this circumferential ring-like pattern in the jejunum. So like this will be there. So it is what? It is this valvulae conventis. It will be seen in a case of jejunal obstruction. It will be seen in a case of jejunal obstruction. Whereas in a case of large bowel, usually it will be having a dilated bowel which is around more than 6 cm. And along with this, it will be mostly peripherally placed. And here you will be able to see this presence of horstations as well. So horstations you will be able to see in a case of large bowel, whereas in a case of small bowel, especially the jejunum part, you will be able to see this valvulae conventis. Okay, yeah. And if it is causing the obstruction, then there will be this air fluid level causing this step ladder pattern of air fluid level, especially in a case of small bowel obstruction. Okay, that is how you will able to differentiate this small bowel obstruction from the large bowel obstruction in X-ray. Then I told you there are one gastric surgery we already discussed, and next we'll see. So if you see, instead of doing a difficult surgical procedure, what we can do is that we can go laparoscopically and we can go and put this band. So this is what this is adjustable band means. You'll put a band and it will cause maximum weight reduction because they are eating less. Obviously, they will having this weight reduction. So at certain point, you feel that no, it still need to be reduced. Then you can reduce the volume. You can just bit pull up. And if you think no, it is not enough, then you need to increase it. Then you increase it. So it is known as what? It is known as laparoscopic adjustable gastric banding. It is known as laparoscopic adjustable gastric banding. Okay, yeah, it is reversible. Then if you see about next one, it is this sleeve gastrectomy. You remove this part of the stomach, okay, and left with the sleeve. It is known as sleeve gastrectomy. Next, we discuss the same Roux-en-Y. It can be done there also. Here also we can do in a case of bariatric surgery. So what we'll do is the same gastrojejunectomy and jejunojejunectomy. Fine, gastrojejunectomy and jejunojejunectomy. And we will do one more procedure which is known as duodenal switch. Which is known as what? Duodenal switch. What we'll do? We'll be having this initial connection with it, whereas instead of taking this jejunum, we'll take up to this ileum. So that what we'll do, the connections and the secretions will be continue till here. Okay, continue till here. So here will be continued with duodenum, whereas here it will be switched with this either jejunum or mostly in a case of ileum. So it is this biliopancreatic diversion. So what we'll do, this biliary and pancreatic secretions will come here, but before that this food particles, they will enter into the small intestine. So there will be less absorption because there is no pancreatic and bile enzymes which are present in there to absorb this food material. Okay, it is the thing. Then we'll move on to the next part. You saw this child who is presenting with the features of here, the child who is presenting with the features of bilious vomiting. Here the child will be present with the features of bilious vomiting. Why? Because this obstruction mostly happens at the level of D2 of this, or D2 or between D2 and D3 of this duodenum part. So in these cases, what will happen is that because of this obstruction, the child will be having the vomiting. So as I told you, whatever the small intestinal complications, it will be presenting with vomiting. So the child will vomit out. Once the child is vomit out, okay, you did this X-ray. You do this X-ray where you will able to see this 1 and 2, where you will able to see this double bubble appearance. So there will be this double bubble appearance. This double bubble appearance is characteristic for this duodenal atresia. Okay, if it is infants. Whereas in later part of age, it can be due to some other complications, like for example annular pancreas as such. Fine. So next, the treatment. Like here the duodenum it is, yeah, good. It can be associated with Down syndrome. Yes, Dr. Quinin. This duodenum, here there is this atresia. So now what you will do, you will just take up this duodenum and you will join it together. Okay, removing this by excising this. So it is what it is, this duodenostomy. So you will do this duodenostomy, or you can do duodenojejunectomy. So mostly we will prefer duodenostomy, remember. So it will be showing this double bubble appearance. Okay, fine. And if it is triple bubble appearance, it will be classically seen in a case of jejunal atresia, and multiple air fluid levels are like a apple peel will be seen in a case of ileal atresia, remember. Fine. This annular pancreas, it is associated with this Down syndrome, and the same atresia also associated with this Down syndrome. Fine. Next we'll come to this complication which is known as intussusception. Now there is a child who is presenting with after a history of vaccination, like after a history of rotaviral vaccination. There is a history of rotaviral vaccination. Yeah. In the case of this rotaviral vaccination, now the child is complaining of pain in the abdomen, and along with this passage of mucus and this blood stained stool, which is known as red currant stools, jelly stools. Okay, where we studied red currant jelly sputum? Yeah, guys, where we studied this red currant jelly sputum? We studied in a case of Klebsiella pneumoniae. We'll study in a case of Klebsiella pneumoniae. Fine. So here, if you are able to see this one loop of the bowel, it is what it is being herniated into this other loop. It is being herniated into the other loop. So most commonly, it is due to this Peyer's patches which is causing this intussusception. So the most common site, it is what? It is this ileocolic. The most common site in children, it is what? It is this ileocolic. It is the most common type. Fine. And the most common lead point here, it is what it is, mucus diverticulum. And in a case of rotaviral vaccinations, there will be this hypertrophy of this polyp. So this is being telescoped into this. Okay, this is being telescoped into this. Fine. Then on ultrasound, yeah, good. On ultrasound, yeah. Yeah, here the air enema, this barium enema will be therapeutic as well as diagnostic. Yeah, good, Dr. Anna. So in the case of ultrasound, you will be able to see this type of sign, which is known as target sign. And next, you will be able to see this type of sign, which looks like a kidney, which is known as kidney sign. Fine. So kidney sign and target sign. Okay. And here there will be few more things you will be able to see. Sausage marks will be mostly present in this right lumbar region, will be on the right lumbar region, and mostly this right iliac fossa will be empty, because there is this telescoping. So this telescoped loop, it will go up. That's why it will be empty right iliac fossa. Okay. So for treatment, what we'll do, yeah, donut sign also will be known as also donut sign. So, and in barium enema, you will see this clock inching, this deformity. There will be this coiled spring deformity. All of them will be seen. Fine. Here, what we'll do, we'll give this air enema. With this air enema, there will be this interception. It will got reduced. Once you start giving air from here, it will reduce. So this is this interception reduction. Fine. Remember. Good, Dr. Rahul. Yeah. Good, Doctor. Yeah, there is the sign of dance here. Good, Dr. Quinin. Gautam. Yeah, good. Fine. Next one is this two valvulus, sigmoid valvulus and cecal valvulus. If you see about the sigmoid valvulus, remember it is always anti-clockwise in nature, and it will be having the feature of coffee bean. Okay, and it will usually originate around this left iliac fossa, and it go to this opposite side. Fine. And on barium enema, you will be able to see there is the presence of this A substrate site. Okay, and for diagnosis, what he will do, he will go colonoscopically and he will detorsify this, okay, and detorsify it, and he will remove this sigmoid component, okay, sigmoid colon component. So usually after detoxification, like detorsion, what we will do, if it is viable, then no issues. If it is not viable, then we need to do the surgical part. Okay, yeah, showing this coffee bean side. Fine. Next, about the cecal valvulus, it will be mostly what? It will be clockwise in nature. And it will be having the feature of kidney. So remember, here you can see classical kidney, right? So this is the classical feature of kidney. So this is seen in a case of cecal valvulus. So ISMET treatment, it is not the detorsion, because colonoscopic, it will be difficult for them to go till this iliac level, okay, to the cecum level. So that's why what we'll do resection at the level of ileum, cecum, and ascending colon. Yeah. Next, there is a child who is presenting with complaints. Now you got a child who is presenting with complaints of delayed passage of meconium. So the mother bringing the child and with the features of constipation. And while asking history, the mother also tell the baby was passed his meconium after 48 hours of birth. So this is classically seen in a case of Hirschsprung disease, where you will see this normal component which is being dilated, whereas this abnormal which is became shrunken, and it is due to this absence of A ganglions, or congenital A ganglionosis of this meniscus and airbox plexus. Yeah, this delayed passage of mechanism is especially what? It is more than 48 hours. Usually it is usual timing, it is within 24 hours the baby will pass its meconium. Remember, and see, whatever this affected part, it will be what? It will be constricted, whereas normal part it will be dilated. Fine. Yeah, that is known as A ganglionosis. Yeah, because of this congenital A ganglionosis, there will be no ganglions for this nerve supply. So that's why there will be no passage of meconium. So there will be no movements of this rectal and the small, means large intestine part. Fine. And the investigation of TISCA, it is this rectal biopsy, rectal suction biopsy more than full thickness biopsy. Fine. Yeah, good, Dr. Quanin. Then management, we have 3 surgeries: Snessen, Duhamel, and Save. These are 3 surgeries for this Hirschsprung disease. याद रखो. फिर उसके बाद आगे बढ़ते types of, like, how you differentiate this ileostomy from colostomy. If you see about this ileostomy and colostomy, see, on outside it looks similar, whereas if you see this ileum, it is what? It is the small intestine. We know in the case of ileum, which is small intestine, the food material will be liquid in nature. So if you make them to open, into this surface, then what? Then this secretions will flow here like this, and it will cause erythema. Okay. So the likewise for that only, in the case of ileostomy, or in the case of small intestine, what we'll do, we'll make this sprout so that we can attach a bag here. So it is what? It is this ileostomy. Whereas in the case of colostomy, if you see this colostomy, it will be having this what? It will come with this formed stools. So we don't need to attach this to the outside. So we can attach to the skin because it will cause less excoriation. Then we can attach a bag and we can collect the fecal matter. So remember, this sprout will be classically seen in the case of ileostomy, whereas colostomy will not have the sprout. Can anyone tell me what is this? Is this ileostomy or colostomy? Ileostomy. Okay, it is this ileostomy. It is this ileostomy, which is actually the type which is known as what? Double barrel ileostomy. Double barrel ileostomy. No, it is not colostomy. See, we are having this loop, means which is sprouted out, means which is coming out. See, this is how this colostomy looks. Will you able to see or differentiate from the outside? Or you see it is attached to the wall. Whereas colostomy will be like this. You can see it, right? It is sprouting from the outside. So this is how this ileostomy and this is how this colostomy looks like. Fine. So this is this double barrel ileostomy. So good Dr. Abneet and good Dr. Anath, good Dr. Rahul. Good. Try more Gautam. Fine. Next, there are different types of fistula. You need to know, like base of the sphincter, there will be like intersphincteric fistula between these two sphincter. Then there will be this sphincter which is passing these two sphincters. So it is what? It is this transsphincteric. If it is above, it is suprasphincteric, and if it is completely outside of the sphincter, it is the extrasphincteric fistula. So all of them, these are these types of anal fistula. And usually they will be having the complaints of soiling of clothes, and along with the soiling of clothes, what they will have? They will have this discharge, foul swelling discharges. Okay, foul swelling discharges. And there is a rule which is known as Good-Sal's rule. It is known as what? It is known as Good-Sal's rule. This Good-Sal's rules tell that whatever this fistula, if its fistula is originating from this anterior part, it will come and open parallelly. Whereas if the fistula originates posteriorly, it will form in a circular fashion and it will come and open at the level of 6 o'clock level. So posterior fistula, it will come and open at the 6 o'clock level, whereas anterior fistula, it will come and open directly in the same axis. Yeah, okay, in the same axis. Okay, fine. Next, about this fissure. This is how this anal fissure looks like. Mostly this anal fissure, it will be seen in a patients with chronic constipation. So remember about this fissure in ano means this will be very painful conditions, because this while the stool comes, it will come and erode this mucosa of this rectum, which causes this anal fissure, and it will be very painful. So this perrectal examination will be contraindicated. The perrectal examination will be contraindicated in the case of anal fissure. Fine. And about cholecystectomy, whenever we remove this gallbladder, we'll call them as cholecystectomy. Fine. And there are different types of choledocholithiasis. Choledocholithiasis means the presence of stones in the bile ducts. Okay, in bile ducts, if there is presence of stones, it is known as choledocholithiasis. Whereas if it is present in the gallbladder, it is known as cholelithiasis. So here there are different types of stones. Either the stones might be formed from there, or it can be formed in the gallbladder and being slipped off into this common bile duct. See, if there is retained common bile duct stone, when we'll tell if it is detected within 2 years. For example, you did a cholecystectomy, and if any stone inside this duct is detected within 2 years, it is known as retained common bile duct stones. Whereas in the case of recurrent stones, it is detected after. So if it is within, it is known as retained. If it is after 2 years, it is what it is, this recurrent stones. It is recurrent stones. Fine. And there are two more types. It is primary stone, secondary stone. In the case of primary stone, it is usually formed in the bile duct. So primary stones of this choledocholithiasis, it will be formed in this common bile duct. Whereas in the case of secondary stones, it will be formed in the gallbladder. Once they formed in the gallbladder, they will slip off into this common bile duct. Okay, so itna yaad rakho. Then about this classification of this choledochal cyst, which is known as Todani classification. So the most common one, it is the type 1. Here what you will do, you will see this, there is only one solitary extrahepatic cyst. Then instead of cyst means it is a dilatation, right? Whereas instead of dilatation, if you see, it is outpouching. If it is outpouching, it is this extrahepatic. And next, if you see this type 3, which is a choledochal cyst, which is one of the simple cysts. And this choledochal cyst, what the management will do is that we'll just remove by cystectomy. Right? We'll remove by cystectomy. Fine. Yeah. Then if you see about this type 4A and type 4B. If you see type 4A and type 4B, in type 4A there will be both extrahepatic and intrahepatic. Both ducts will be there, both cysts will be there. It is extrahepatic and intrahepatic. Whereas in the case of type 4b, there will be only extrahepatic ducts. This will be there. Fine. Whereas in the case of type 5, only intrahepatic will be there, which is known as Caroli's disease. It is known as Caroli's disease. See, so in the case of type 1, it is just solitary. It is single and extrahepatic. If it is single but it is like a outpouching, it is known as diverticulum. And third one, it is choledococele. It is choledococele. And the fourth A, it is this extra and intra. Both will be there. Whereas in 4B, it will be what? It will be extrahepatic only. And it is multiple in nature. And in 5, it will be multiple intrahepatic cysts, and it is known as what? Caroli's disease. Fine. So these are the things you need to remember. Next, you saw a patient who is having this pain in the left epigastric region and along this left hypochondric region and along with this epigastric pain. And asking the patient still, he also feels the same pain which is being radiating to the back. And under evaluation, you will be able to see on CCT this kind of inflammation over the pancreas. So it is what it is, this acute pancreatitis. It is acute pancreatitis. And the causes of this acute pancreatitis include, the most common one, it is this gallstones, followed by this alcohol. And in a case of children, there might be this blunt trauma, like for example cycling trauma, which causes pancreatic head injuries, or pancreatic injuries which causes this pancreatitis. Fine. And there are like few viral infections like cytomegalovirus, Coxsackie virus, and mumps virus. All of them, it will cause this pancreatitis. We know in a case of pancreatitis, there will be elevation of this serum markers like serum amylase, serum lipase. Fine. And in a case of post ERCP, endoscopic retrograde cholangiopancreatography, what we'll do, we'll put up a probe. Okay, we'll put up a probe, a stent inside to see the component into this biliary tract. So in such scenarios or in such cases, what will happen is that this pancreatic duct, via pancreatic duct only we need to go. So this may damage the pancreas and can cause pancreatitis. Fine. So this is the pain in the epigastrium, and it is radiating to the left side of the back, especially, and it will be relieved by sitting. Okay, there will be this prayer sign, also known as Mohammedian prayer sign. It is known as Mohammedian's prayer sign. Yeah, this question has been came many times, okay, about this pancreatitis. So you should be vigilant enough. Fine. And this pancreatitis can lead to this kind of complications. In a case of hemorrhagic pancreatitis, you will be able to see this type of signs. If it is around this umbilicus, it is known as Cullen sign. And if it is around the flank region, it is known as what? It is known as gray Turner sign. Around the flank region, and it is known as gray Turner sign. And there is also one more sign around this inguinal region. It is known as Fox sign. Okay. Then this pancreatitis, they can cause this paralytic ileus. And because of this paralytic ileus, there are a few features which include your cutoff sign of the colon. There will be a sign which is known as cutoff sign. The colon appears that it is being cut off from the rest part of the colon. So colon cutoff sign, it is typical for this pancreatitis patients. Fine. And the investigation is CECT. And for treatment, what we need to do, like enteral nutrition is better. In a case of mild to moderate, the enteral nutrition, it is better than the TPM. Okay. Next, we need to provide them with multiple fluids, because this pancreatitis patient also, they will proceed or they will present with the features of vomiting. Fine. And as there is a pain, we need to provide analgesics like methimazole and buprenorphine. Fine. And what are the indication of TPN in a case of pancreatitis? If you see here, like you need to give TPN in a case of shock or in a case of any severe pancreatitis. In a case of severe pancreatitis shock, you need to give this TPN, because in a shock also the patient cannot eat, and in a case of severe pancreatitis, if he drinks a sip of water itself, then he will be started having this pain. Okay, remember. Okay, just remember these things. Next, about this few malignancies: insulinoma, glucagonoma, and VAPoma. Okay, insulinoma, glucagonoma, and VAPoma. This insulinoma, we know it produces the insulin. So if it produces the insulin, it will cause hypoglycemia. So it will be characterized by a triad which is known as Whipple's triad. There will be symptoms of hypoglycemia, and the symptoms of hypoglycemia, it will reverse once you give glucose. Okay, the improvement of symptoms after taking the glucose, फिर उसके बाद the blood glucose level will be at the level of hypoglycemia. So there is a symptoms of hypoglycemia, and there is the actual blood glucose level which is less, and along with this there is an improvement symptom which happens after the taking the medications, or especially the oral glucose. Fine. And next, this diagnosis. The diagnosis, what we can do is that we can do somebody to have a fasting levels, fine. And for management, we can use diazoxide, and along with this, we need to give hydrations. Okay, and as a main modality, this insulinomas, we know this insulinomas will arise from the pancreas. So either if it is at the tail, we can just cut off and remove the tail, or if it is at the head, what we can do, we can remove by enucleation. If it is at the level of head, we can remove by enucleation. We can remove by enucleation. Remember. Fine. Next one, it is what it is, this glucagonoma. Next, this glucagonoma, it will be presenting with this peculiar type of rash. We know this glucagon, it will cause increase in blood glucose level. So there it will cause increase in blood glucose level, and it will cause this type of dermatitis, which is known as necrolytic erythema migrans. It is known as necrolytic erythema migrans. So in which of the following tumor or which of the following conditions you will see this type of necrolytic erythema migrans, it will be classically seen in a case of glucagonoma. It will be classically seen in a case of glucagonoma. Remember. Next, if you see the next disease, which is known as vasoactive intestinal peptide tumor. This kind of vasoactive intestinal peptide tumor, also known as VIPoma, it is also known as Werner-Morrison syndrome, also known as pancreatic cholera, also known as VADA syndrome. It is also known as VADA syndrome. See, in this scenario, the patient will be experiencing this watery diarrhea 4 to 6 times a day. So it is lead to this electrolyte loss of sodium, chloride, potassium, and bicarbonate. Okay, all of these things will lead to this increased, along with this increased blood sugar levels and hyperglycemia, along with hypercalcemia, and hypercalcemia. So it's dono hoga. So remember, it is the VIPoma which mimics this cholera, and along with this cholera, there will be a presence of this loss of sodium, chloride, potassium, and bicarbonate. Along with chloride, potassium, sodium, and bicarbonate. So all of this following will be seen along with this diarrhea, and this is the typical for this VIPoma, which is also known as WDHE, VADA syndrome. Okay, yeah. Next, we'll move on to this general surgery component. For GRD, we use 24-hour pH monitoring. If you see this general surgery part, okay, you need to know about the sutures. The sutures, few of them they are non-absorbable, and few of them they are absorbable. So remember about this non-absorbable suture. The natural non-absorbable sutures include silk, nylon, okay, silk, nylon, and steel also it's a natural. So remember about this silk and nylon. Whereas synthetic one, it includes this polypropylene, polyester, and Dacron. So remember these 3 points: polypropylene, polyester, and Dacron. And absorbable natural one, it is this catgut. Okay, we know this catgut, it is absorbable and it is natural in nature. And synthetic one, which includes polyglycolic acid and polygalactic A. Okay, this 2 and finally this PDS. So remember, so in VIPoma, as I told you, right, there will be features of diarrhea will be mentioned, and there will be features of this electrolyte imbalances, and hyperglycemia and hypercalcemia will be given. So if you try to rule it out, you will be able to get these things correct. Okay. Then about the suture techniques. If you take a bite, if you take an individual bite, so this is known as what? This is known as simple interrupted suturing. Just one bite, after one bite you are tying, after one bite you are tying. So this is simple interrupted. Okay. Whereas in a case you took a bite and you are continuously doing it, so it is what it is, this simple continuous. It is known as what is known as simple continuous. And there are 2. Yeah. Catgut is from this ship gut. I guess guys, few of you is not in live. I guess just press this live button so that you will be in par with this class. Fine. Then there is 2 mattress, horizontal mattress and vertical mattress. If you see this mattress, just remember about this vertical mattress. Remember about this one mnemonic. This dur se pass means you take a bite means distant to the wound or distant to this incision site. Then you cover it up. And when you take outside, you took up the next bite which is near to it. So you took a bite, you came along, and you took up the needle, and you took up the next bite, and you took up in, and you took up the needle. So you just pricked and you went along, and you taken the bite here, you opened up, and then you just went here, and from here you just came nearby, and then you tied it. Okay. So see. So it is what? It is the wound. So you took up this bite, like you put the needle here, and you went along inside, and you took up out the needle. So take it, जैसे तूने ऐसे किया तो बाहर निकला, तो you just took it out. So you just pulled out the string, and then what you do, you prick again. Okay, you prick again from here. So here to here. Okay, here to here you pull out, and when you pull out, you will have two ends, right? From starting end and this end. Then you tie here. So this is known as vertical mattress. So this is known as what? This is known as vertical mattress. So okay, dur se pass se. Okay, this is known as vertical mattress, whereas opposite of this, it is this horizontal mattress. Horizontal mattress, it will be done in this side. Okay, it will be like this. Then you take from here, you merge it. Okay, like you took a bite. Okay, you came along and you took a bite here, then you came along and you tied here. This is how in vertical mattress. So in horizontal mattress. So just remember this vertical mattress, so that you won't get confused with it. So you can solve this another one easily. Fine. And there are two knots. One is known as square knot, another one is known as granny knot. How will you differentiate these two knots? You just draw a intersecting line. If you see here, they will ask you, means which of the following suturing techniques has been used in this condition. So you need to identify whether this is horizontal mattress or vertical mattress. They will give you which surgical technique has been performed: subcutal suturing, surgical mattress, vertical mattress, or horizontal mattress. Like that they will ask you. Here about this knots, if you see, mostly you need to draw this line. If you see, if the same color is present, okay, see here it is red color which is above, red color which is above. So it is what it is, this square knot. But if you see here the violet color is above, here the pink color is above. So if two different colors are there at this intersecting junction, it is granny knot. So this is square knot, which is also known as a reef knot, which is one of the stablest knots. Okay, yeah, stablest knot. Remember, fine. Next, we'll move on to this classification of burns. If you see about this classification of burns, in the case of first degree burns, it is just involvement of the superficial epidermis. So there will be just erythema will be there, and it will be painful in nature. Whereas second degree partial tear, there will be formation of this blisters. There will be these vesicles and the blister formations will be there. Okay, especially this blisters formation will be there, and it also will be painful in nature. Partial in second degree partial will be painful in nature, whereas type 3 it will be around the same or less painful in nature, less painful, and there is a presence of this pain prick sensations will be present in a case of third, means like second degree deep burns, whereas in a case of third degree burns, which is deep burns, there will be no sensations. Okay, whereas if it is involving till the muscles and this bones, then it is the fourth degree burns. Okay, fourth degree burns. This is how you will classify the burns. And after that classification, you need to calculate this fluids. How much amount of fluids you will give. Previously we used to use this Parkland formula. Now we are using this ATLS formula. We are using this ATLS formula. For this ATLS formula, remember, for adults who is more than 14 years of age, in most of the scenarios it is 2 ml into body weight into kg in percentage of burn surface area. Okay, it is the 2 ml in 2 into body weight into percentage of body surface area which is being involved. Whereas if it is child is less than 14 years, if the body weight is less than 30 kg, then it is 3 ml. So 14 children, it is third alphabet, so 3 ml, and are less than 30 kg. Here also 3 is there, so it is 3 ml. Or if it is an electric burns, will be what? Will be having this 4 ml. So see, if it is adults, it is 2 ml into same body surface area which is involved along with this body weight. Okay. Then if it is electrical, it is 4, and if it is child, it is 3. Child 3, adults 2, and electrical 4 burns. Okay, remember, this is the thing you need to remember. Next, about this type of graft, CPC, this is the partial thickness skin graft, and it will be having the gaps so that you can stretch and you can cover the maximum surface area. But only problem here is that it will be having a maximum secondary contraction. So because of this maximum secondary contraction, what will happen is that this will have this very less or very poor cosmetic outcome. Okay, very less or very poor cosmetic outcome. Next one, if you see this type of full thickness, this type of graft which is known as full thickness skin graft, and it is known as Wolfie's graft. It is known as Wolfie's graft. Here the cosmetic appearance will be better. You can see, right? Here the cosmetic appearance will be better because of this less secondary contraction. We'll move on to the next part. If you see the ulcers, if you see there is without any blood, and this gaiters area, around this area where there is most common venous ulcers occur. So it is what it is, this venous ulcer. And if you see this type of necrotic base, it is what it is, this arterial ulcer. And if you see around this area, around this foot, okay, around this foot, which is because of this loss of sensation, this ulcer occurs. It is what it is, this neuropathic ulcer. It is this neuropathic ulcer. And next, if it happens on this pressure areas, for example, if someone is lying, he will He means if it is someone is bedridden, then he will keep his leg like this only. So this causes this ulcer, which is known as pressure ulcer, also known as decubitus ulcer. Decubitus ulcer. Fine. And next, in born patients, you will see this type of ulcer, which is known as Marjolin's ulcer. They'll be mentioning, this Marjolin's ulcer. Okay, Marjolin's ulcer, and this Marjolin's ulcer, it is be pre-malignant for this squamous cell carcinoma. Next, you need to know about this type of parotid gland malignancy. The most common overall, it is this pleomorphic adenoma. And this pleomorphic adenoma, P for P, remember, it will be having the pseudopodia projections. So you should be careful enough to remove. While removing this, you should be careful enough, and you cannot do enucleation. So you need to do complete excisions in such cases. Okay. And it is most commonly at the tail of parotid glands. And Warthin's tumor, remember, it is most commonly or exclusively seen in a case of parotid glands. It will be exclusively seen in a case of parotid glands. Fine. And it has a defined capsule. So unlike pleomorphic means adenoma, it will be having this pseudopodia extension. So it will be having this neural involvement as well. So we cannot do enucleate and excise. Whereas Warthin tumor, it will be having this capsule. So we can do enucleation and we can remove it. Fine. Just remember. And then this mucoepidermoid cancer, it is the malignant tumor. It is the most common malignant tumor of this parotid glands. Okay. And it will be associated with this lymph node metastasis, and it will be associated with this lymph node metastasis. Fine. And next one, it is this adenosystic. Adenosystic, it is the most common malignant tumor of submandibular gland. It is the most common malignant tumor of this submandibular gland. Okay. So just remember about this few parotid malignancies, it can be asked. And about this management of this cleft palate. Okay. We see about this cleft palate, this unilateral cleft lip. If there is just only unilateral one, remember it is 5 to 6 months. If it is bilateral, it is 4 to 5 months. So if it is bilateral, it is 4 to 5 months. And if it is cleft palate, if it is soft cleft palate, remember it is around the same, it is 6 months. Whereas if it is hard palate, if it is hard one, we can replace later on at 18 months. Okay, fine. Next, you say a cleft palate. Okay, you say a cleft palate, which is means if there is any cleft palate along with this hard palate and soft palate, then we need to do two different surgeries. For example, if there are hard palate involvement or hard palate cleft also, soft palate cleft also. So we cannot do it simultaneously. So we need to do one by one. So see, soft palate S for S will be done at usually at 6 months. S for S it done at 6 months. Yeah, it is due to the non-fusion of maxillary and medial nasal process. Yeah, good, Dr. Abdit Singh. Good. Fine. And about this hard palate, it will be done at around the same, around the 18 months. Fine. Whereas if there is lip, where there is lip, cleft lip which is being associated, remember the first thing we need to do, it is this which is this lip along with the soft palate. So we need to do lip along with the soft palate along with this hard neck, followed by this hard palate. So first is the soft palate with the lip, and second is the hard palate, as usually we do. So hard palate, it is same, it is 18 months. So don't need to bang your heads on hard palate, which is 18 months everywhere. Whereas in the case of unilateral one, see, if it is unilateral one, see for this unilateral one, which is the most earliest, see the both soft palate at 6 months and unilateral it is around 5 to 6 months. So whichever is the earliest will take up in. So unilateral means the earliest it is 5 to 6 months. So we'll write as 5 to 6 months. Fine. Whereas in the case of bilateral, usually bilateral cleft lip itself we need to do at 4 to 5 months. So here also we'll do at 4 to 5 months. Okay. So itna yaad karo. So if it is unilateral cleft lip matlab 5 to 6 months. If it is bilateral, then it is 4 to 5 months. And if it is unilateral just soft palate means S for S and S for 6, it is 6 months. And if it is hard palate means, remember, it is 18 months. So itne sare aapko yaad rakhna. Then about this TPN. If you see about this TPN, mostly in a case of pancreatitis which is intractable, we will use it. So we'll see what are the complications or what are the indications for use. If there is a bubble is small, if we will call them a short bubble, so we'll use this TPN, and we also use one more drug which is known as what? Teduglutide, which is known as teduglutide. Yeah, okay, teduglutide. Next about this ECF, if there is enterocutaneous fistula which is having more than 500 ml of output per 24 hours, then we will use this total parenteral nutrition. And if there is any acute and active IBD, like acute active Crohn's disease, then we'll use this TPN. So we already discussed, we just go and see. Okay. And about this initial stages of pancreatitis, and if there is any prolonged ileus for more than 72 hours, then we will use this. And what are the complications? Either there might be two complications, either how we are feeding, it may complicate the patient, or how we are putting the line which are putting for the center line, it may have some complications. The feeding complication, it is known as re-feeding syndrome. You are feeding them, it is known as re-feeding syndrome. So remember, in re-feeding syndrome, most of them it will be decrease. So it is what? It is decrease in PCM. It is decrease in phosphate, potassium, and magnesium. So there will be decrease in phosphate, potassium and magnesium, or else remember it as PM. Don't get confused. So it is this phosphate, potassium and magnesium. Okay. So here the main culprit is hypomagnesemia. Okay. And about this line may, about this line related means this line may undergo infection which causes this sepsis, which is the most common cause for this removal of these lines. And while doing this line, we can puncture the pleura, which is this pneumothorax, or else we can do, means while doing, if there is an entry of air, it is this air embolism. Fine. Next one, it is this thoracic duct injuries. It can, while inserting, we can injure the thoracic duct, or we can injure the cardiac tamponade. Fine. Heart will lead to this cardiac tamponade. Fine. Next, we'll see some extra age topics. See about the CEAP classifications. Remember one thing: C0, it is no dilatation. C1, it is just small dilatation, which is known as telangiectasia. C2, remember this 2 for V. So V means for, it is what? It is this varicose vein. Fine. And C3, it is what? See, make this 3 into like this. So it is what? It is this presence of edema. So edema, it is C3. Fine. And C4A, initially, if there is any venous pooling, there will be formation of pigment. So first one, it is this pigmentation. So if there is pigmentation, then the macrophages will come and they will form this scar inflammation. So it is known as what? It is known as lipodermosclerosis. In B, it will be forming this lipodermosclerosis. And C4C, it will cause us corona phlebectotica. It causes corona phlebectotica. And C5, it will be what? It will be this healed ulcer. C5, it is the healed ulcer, whereas C6, it is the active ulcer. Okay. So remember, it is C2, it is varicose vein. C3, it is the edema. C4A, it is the pigmentation. And C4B, it is what? It is this lipodermatosclerosis. And C4C, it is the corona phlebectotica. And C5, it is the healed ulcer, whereas C6, it is what? It is this active ulcer. Remember. So these are the things you need to remember in the case of varicose veins. Fine. And if you are able to see this type of pneumobilia, small bowel obstruction and gallstone, it is seen in a case of gallstone ileus. Okay. This triad is known as Rigler's triad. Okay. Fine. Next, about this vascular things, if you see, if there is any aortoiliac obstruction, it will be having this claudication at buttock, thigh. Okay, buttock, thigh and calf, and along with this there will be erectile dysfunction, which is known as Littre syndrome. So if it is at the level of aortoiliac bifurcation, so it is at the level of, it will cause claudication in buttock, thigh, also erectile dysfunction. Okay, it is known as Littre syndrome. Just remember. Whereas if it is at the level of common femoral vein, it will cause at the level of thigh and calf. Okay, whereas rest disease, the rest are below to this, it will cause only calf coagulation. Okay, calf claudication. So if it involvement of this femoral, then there will be what? There will be thigh claudication as well. Whereas in the case of aortoiliac disease, what will happen? It will cause even buttock claudication, and there is a presence of this impotence, which is known as what? Erectile dysfunction causing this impotence, which is known as Littre syndrome. It is known as Littre syndrome. So remember. It's about this Boyd's classification. If you see this grade 1, it is for this Buerger's disease, which is this thromboangiitis obliterans. Okay. So in grade 1, there is initial pain, but he continues to walk. Whereas in grade 2, the patient can walk, but he will be still having the pain. Whereas in grade 3, the pain compels the patient to take rest. Fine. Whereas in grade 4, in rest also there will be a pain. So this was asked in the previous FMGE examination. Remember. And this is this, which is used to prevent the DVT, which is this pneumatic compression device, and this is this negative pressure wound therapy. Okay, for improve the wound healing. Fine. Yeah. Then there are a few instruments. This is the Joel's thyroid retractor, which is used to retract the thyroid gland. Next, it is this abdominal wall retractor, and this is the proctoscope. And there are a few more retractors. If it is flat, it is this Morris retractor. If it is like a question mark, it is known as Diever's retractor. And if it is looking like a N, it is known as Doyen's retractor. Fine. And next, if you see this small one, or this L-like retractor, it is known as Langerback retractor. And if you are able to see this type of tooth, it is known as Alice tissue forceps. And this is the bipolar cautery, which is having this two. And if it is just one, it is this unipolar cautery. It is this unipolar cautery. And Babcock's forceps, it will be like this heart. So it is this Babcock's forceps, which is used to handle the spermatic cards and fallopian tubes. Fine. And next, this is this artery forceps. And this is the Humby's knife, which we used to extract or which we used to take the skin graft. Fine. And this is the needle holder. And needle holder will be having a central depression. Remember. Very confusing IBQ. Which one? And this is this linear stapler. And this one, it is the stapler remover. Stapler remover means we use for this closure of this abdominal wall, closure of the skins. Fine. And this is this circular stapler, which is used for this bowel, especially this bowel anastomosis. Fine. Then this is what? This is this Romo-Vac drain. And this is the open drain, which is this corrugated drain. And next, this is what? This is the semi-closed drain, which is what? Which is this Jackson Rate drain. This is this T-tube, which is used for cholangiogram. Fine. And next, if you see this one, this is what? This is this harmonic scalpel. Okay. And this one can cut and seal at same time. Okay. Yeah, that's it, guys. That's it about the surgery part. Okay. I will have this gynecology part left. I will do the gynecology part. And if you have any doubts, please let me know. We'll discuss it once. Graph, there are two graphs. Like there is one, this which is known as, yeah. Okay, fine. Yeah, there is no any issues, I guess. Yeah. In graft, what do you need? Like in graft, what do you need? I couldn't get you. In graft, if you see, there is just partial thickness and full thickness skin graft. In partial thickness graft, you will do this more openings and it will be more stretchable. Okay. And it can cover most of the surfaces. And wherever you harvest, you can harvest for multiple times. And see, this will be, this won't be having a proper, this won't be having a proper cosmetic appearance. It will be having a improper, or it will be having less cosmetic outcome because of this secondary contraction. Means it undergoes this contraction, because of this it won't look good. Whereas in a case of full thickness skin graft, you will bring this full thickness and you will keep it, so the cosmetic outcome will be better. Okay, that is the thing you need to know. And the same, like surgery medicine means there will be few things you need to think, like what is the next step, like that you need to think and answer. Whereas obstetrics and gynecology, let me tell you, like you read this file, it has most of the things which you need for your examination. In gynecology, it is not mostly like what is the next step kind of, there is very less kind of next step. Everything, it has a conceptual meaning. If you just understand and click out these concepts or click out this important keywords, then you can make them in line. Once you make them in line, you will get this correct answer. Yeah, look, means in surgery, that's what, like in each questions you need to get the grasp. Like for example, let me tell you, like what are the mistakes which we do during solving of questions. There are 3 levels of mistakes can happen. One, you don't know the stuff. Okay, keep it apart. Second, you know the stuff, but you are unable to apply it. Third, you know this stuff and you try to apply it, but you got confused between 2 options. So these are the 3 various levels. So if you don't know, then you need to study. If you are unable to get the catch, then you need to study or you need to do multiple questions, so that you need to get the grasp or the keywords from the question. And third, like if you are getting confusion, means then it is a small point of delineation. You need to go back to the topic and try to make a differential point between option A and option B. Okay, if you make these 3 things correct, then you will able to solve most of the questions correct. Okay, this is what I tell for the most of the students, and it actually works, and you can also try it. Okay, this is my personal opinion. Fine. Okay guys, we'll move on to this gynecology part. First, you saw this female who is presenting with these features of this swelling, which is around the level of anterior 2/3 and the posterior 1/3 of this labia majora. Okay, you saw this swelling. So what do you think of? Which cyst is this? It is what? It is the cyst at this Bartholin's gland. It is the Bartholin cyst. It is a Bartholin cyst. And the most common complication, like our most common presentation, is that it is flocculent. It is flocculent and it is not intercelling. It is like if it is something is there, right, it will be having this kind of foreign body sensations. Okay, so because of this insecurity, the female will be complaining and they will be coming off. So usually it will be flocculent and without any tenderness. Whereas if it gets infected, if this Bartholin cyst becomes an infected abscess, okay, then it will be causing painfulness. So if there is just this cyst, then we'll do marsupialization. Whereas if there is presence of this abscess, then we do incision and drainage. Then we do incision and drainage. As like in breast abscess, we do ultrasound guided multiple aspirations. As like here as well, what we do incision and drainage. Means first we do marsupialization followed by this incision and drainage. Fine, just remember. Next, you saw this 15-year or 16-year-old child who is presenting with this well-developed breast and well-developed hairs and everything. But her mother complains that she didn't attend her periods yet, but she complains that every month she is having this lower abdominal pain. Okay, so you plan to do an evaluation. So you did a visual examination where you can able to see this type of bulging out or bluish bulging out type of hymen. So it is the classical case of good Dr. Gautam and good Dr. Anar. It is what it is, this cryptomenorrhea. It is cryptomenorrhea. It is what it is, this cryptomenorrhea, which is because of this imperforate hymen. Imperforate hymen. Okay, and usually it is imperforate hymen. Okay, see this is the marsupialization which are doing here for this Bartholin's cyst. Fine, and this is the cryptomenorrhea, and there are mostly it is because of this imperforate hymen, and sometimes it might be because of this persistence of this transverse vaginal septum. Okay, in those cases we need to go abdominal and remove it, but mostly it will be imperfect hymen only. So in this we'll do a cruciate incision. We do this cruciate or X-shaped incisions so that it won't heal it back. Okay, so that it won't heal it back. And in the case of this, we won't do per vaginal examination. We'll do per rectal examinations. When we go and do this per rectal examinations, you will able to see there is this bulging of this anterior wall of the rectum. And in anterior wall, you will able to see the bulge or you will able to feel the bulge. Okay, so you won't do this per vaginal because she is child, right? You cannot do PV in her. So you do per rectal examination. Fine. And then how will you differentiate this primary amenorrhea? So mostly mostly in a case of primary amenorrhea, like mostly there will be findings given. First, the karyotype. So if the karyotype, if she is female, fine, then what we need to look is we need to look into the uterus, like whether and secondary sexual characteristics. Fine, if there is the presence of uterus, if the uterus is present, but if it is an infantile shaped uterus, okay, and the gonads are streaky gonads, it will be classical case of Turner syndrome. It is a classical case of Turner syndrome. Next, if the uterus is absent, but the secondary sexual characteristics like breast development is there and pubic hair and axillary hair are there, then you will think of which disease? Yeah, guys, you will think of Mullerian agenesis. Because hair is present here, but only this uterus is absent along with this blind end vagina. Fine. Whereas in the case of testicular feminization syndrome, there will be well developed breast, but there will be absent of this pubic and axillary hair because that testosterone is not acting. This dihydrotestosterone is not acting on the receptor. Okay, so there will be absent of pubic hairs. Okay, there will be plus breast development will be present. Okay, there will be proper development of the breast. Then in the case of Sway syndrome, it is the 46XY chromosome along with the streaky gonads. Here the uterus also present. Okay, but see, there is also vagina also normal developed, but they won't come into this secondary. So they won't have this proper secondary characteristics because there is this streaky gonads. So remember, it is the Sway syndrome. Fine. Whereas in the case of Kalaman syndrome, whereas in the case of Kalaman syndrome, it will be associated with this. All FSH and LH will be decreased. Along with this, it will be presented with anosmia. Yeah, it is this hypothalamus problem. It will be having this anosmia as well. Yeah, good guys. So these are the few points you need to remember. Like if there is uterus present and all the hairs present and breast development is there, but uterus is absent, you will think of Mullerian agencies, which is this MRKH syndrome. Whereas if uterus is absent and breast is there, but there is no pubic and axillary hair, then you will think of androgen insensitivity syndrome. Whereas in the case of Swyer syndrome, the chromosome will be 46XY, but there is a presence of uterus, but the streaky ovaries and loss of secondary sexual characteristics, it is the Swyer syndrome. Whereas in the case of Turner syndrome, there will be this shield-shaped chest along with this widely placed nipples, and along with this, they will be having this short stature and streaky ovaries, 45XO chromosome. 45XO. Turner it is, yeah, 45, it's 45XO. Next one, it is what it is this? Ambiguous genitalia. Okay, that should be there. Fine. Okay, because it is new, because content is available everywhere. In your main notes only from I prepared, like around the same will be here, will be there. Okay, but thing is that it is how concisely we are taking up. Fine, because if you read it new and you are unable to correlate, there is no mean of having and reading this. Okay, so I want you to correlate from your main notes to these notes, and once you have this proper correlation, if you read this note, it will be enough. Okay, that is my part. In a case of ambiguous genitalia in males, the most common cause, it is what it is this? Testicular femorization syndrome. Whereas in females, it is most common cause, it is what it is this? Congenital adrenal hyperplasia. It is this congenital adrenal hyperplasia. Just remember. Okay, there's 2 points. In a case of, the most common one, in a case of congenital adrenal hyperplasia, it is what it is this? 21 hydroxylase deficiency. It is the 21 hydroxylase deficiency. Fine. And next, if you see this semen analysis, you can use it as a source of your revision. 21 hydroxylase deficiency. Fine. Next, if you see about the semen volume, the normal it is around 1.4 based on the new update, and total sperm number it should be around 39. Okay, 39, around 39, and total motility should be around 42%. Okay, previously it was 40, now it is increased to 42. Now on the progression should be 30, and the main one, it is the forms, which is this morphology. The morphology should be 4%. Okay, morphology should be 4%. Okay, then you should know about few terms. One is what? One is known as aspermia. Remember, it is not aspermia. It doesn't mean that absence of sperms. Aspermia means absence of semen. Okay, if it is azoospermia, it is absence of sperm. Absence of sperm. Remember. Okay, it is the absence of sperm. Okay, asthenospermia means the motility is impaired. So there is no proper progressive motility. So just remember all these terms so that if they ask, you will be familiar with it. Fine. And next, about these 3 diseases, and 1 should be asked in your examinations, or sometimes 2 can be asked in your examinations. Okay, fine. You have a first patient who is presented with this features of this strawberry cervix. And here you see this trichomonas. You know this trichomonas, right? Trichomonas, what is the color of discharge? So remember this, our flag is Tiranga flag. So the tricolor flag. So the third color is what? It is the green. Okay, third color is kya? It is the green. So remember, it is the green frothy discharge. Okay. Third color here are in the LED, means in the traffic light there will be red, yellow and green will be there. Third color it is kya? It is the green. So remember, it is the green. Okay, third color kya? It is the green. So this trichomonas, it will be what? It will be this green frothy discharge, and the pH will be more, and it will be having this strawberry vagina. And we know this strawberry vagina, it is caused due to this trichomonas vaginalis, and it will be having this twitching motility. Okay, twitching motility. And for this cultivation, we can use this Diamond's media, and for this treatment, we'll use metronidazole. So trichomoniasis, green frothy discharge, and there will be this what? There will be this strawberry cervix, and for culture, we'll use this Diamond media. And this culture will use this Diamond media, and there will be twitching motility, and treatment will use metronidazole. Okay, and then there will be this old, means pregnant patients who is our OCP pills patients, who is a diabetic patients, now presenting with cardi-wide discharge. With more pruritus, and while checking the pH is less than 4.5. The disease which is mainly associated with this less pH and showing this cardi-wide discharge, it is seen in a case of candidial vulvovaginitis or candidiasis. And in candidiasis, this will show this budding yeast, okay, and pseudohyphae formation as well, and this can be cultured in seborrheic dextrose agar, and we know it is what it is this candidiasis. So we will use what? We'll use this fluconazole. We'll use this fluconazole or clotrimazole pessaries. Fine. Next, if you see this bacterial vaginosis, it is what it is dirty white. Remember, it is bacterial vaginosis. It will be having this dirty white discharge. Dirty white discharge, which will be foul swelling in nature. And this dirty white discharge, if you see on examination, you will be able to see this type of cells. Means this epithelial cells having this lot of bacilli. Yeah. Good Dr. Naresh, good Dr. Anna. Yeah. Good Dr. Gautam. So it is what it is this clue cells. These clue cells, they are exclusively are mainly seen in a case of this bacterial vaginosis, and we'll use this criteria which is known as Amsler's criteria to diagnosis. There will be this grayish white or this dirty white discharge, along with this pH will be more than 4.5 and presence of clue cells, and there will be this whip test will be positive. There will be this fishy odor, and adding KOH you will be able to see there is the smell of fishy odor. So this will be seen in the case of bacterial vaginosis. So treat this bacterial vaginosis, will use metronidazole. So remember, trichomoniasis and bacterial vaginosis will use metronidazole, whereas in the case of candidiasis will use fluconazole. Yeah, good. We'll use this Amsler's criteria. फिर आगे बढ़ते हैं. You have a patient who is having this features of dysmenorrhea. There is a painful menstruation, painful menstruation, and on evaluation you will be able to see there is this globular enlargement of the uterus. It's the symmetrical enlargement of the uterus, and on histopathology you will see the presence of endometrium in myometrium. Okay, so it is what it is this. Yeah, it is the feature of this adenomyosis. The most common symptoms include this menorrhagia or increased menstruation, okay, then dysmenorrhea, pelvic discomfort, and the backaches. So pelvic discomforts, all of these things. So you will see there is a symmetrical enlargement. It is not irregular, it is a symmetrical enlargement of the uterus, but this enlargement will not exceed 14th week size. So it should be always less than 14 weeks. So this is the case of adenomyosis. So in such a cases, agar patient is fertile, okay, the patient want to preserve fertility, तब हम क्या दे सकते हैं? We can use this NSAIDs for the pain, or else we can use this LNG like Mirena to be kept inside to decrease this hormonal action. Okay, so this is we can use if the patient wants to be fertile or wants her uterus. If not, the final management, it is what it is this total hysterectomy. It is the total hysterectomy. Fine. It is this adenomyosis. It is a regular or globular enlargement of this uterus. Whereas if you see this type of irregular enlargement of this uterus, and the patient is also complaining of menorrhagia, and this size of this uterus, it is exceeding, or if it is more than 14 week size also, it is what it is a classical case of fibroids. And we know this fibroids, it is also known as leiomyoma. It is the most common benign tumor. It is the most common benign tumor of the uterus, and the most common type it is it is what it is this intramural or the interstitial type of fibroid. Okay, whereas the submucosal fibroid, it produces more symptoms like menorrhagia, whereas the most common type it is the intramural. This fibroid can undergo degenerations. The degenerations may include hyaline degeneration and other red degeneration, which is seen in pregnancy. Hyaline means just hyalinization, okay, whereas in red degenerations it will become red beefy appearance, and there will be increase in ESR. So there will be what? There will be increase in ESR and red beefy appearance. Okay, red beefy appearance, and all of them will be seen during the second trimester of pregnancy. It is known as red degeneration, and the main management इसमें क्या करेंगे हम? Conservative management करेंगे, and rest and analgesis will give. Okay, so this is a case about this red degeneration. Next, this is an ultrasound image where we'll be able to see this hypoechoic mass, which is actually the fibroid. Fine. Okay, so you use initially ultrasound for management, and if there is infertility, if there is a cause of infertility, then we'll do this myomectomy, or okay, or if it is causing some pressure symptoms, then we'll do hysterectomy. Remember, so if it is case of if the female is presenting with history of fibroids, which is mostly submucosal or any other or intramural type of fibroids, but all other causes of this infertility are being ruled out, then next you should do it is the myomectomy. Okay, so you can do like hysteroscopic myomectomy as well. Okay, hysteroscopic myomectomy as well based on the location of this fibroid. Fine. And if it is old age patients having this pressure symptoms causing this urinary symptoms, this constipation, then in such cases you can do hysterectomy. Fine. So the asymptomatic patients, nothing do. If it is symptomatic, we can give some of this medical managements like OCPs. Then if it is asymptomatic, rapidly growing or pedunculated means, then we can go for surgical options. Okay, because this pedunculated, they can undergo torsion. They can undergo torsion and unexplained infertility, because all other causes of this infertility are ruled out. In such cases, we'll go for definitive surgery management, which is this removal of this fibroid and or removal of the uterus. Fine. Next, about this endometriosis. If you see in the case of endometriosis, the patient will be having a typical complaint. Kya bolenge? There is a feature of painful menstruation, and there is a painful during intercourse, there is a painful which is known as dyspareunia, and there is a features of infertility. So all of them, they are the classical features of endometriosis. Endometriosis, it is the presence of endometrium. It is the presence of endometrium outside the uterus. Endometrium outside the uterus. Yeah, good Dr. Gautam, good Dr. Finan. See, adenomyosis, we saw this is the presence of endometrium inside the muscle layer, whereas in the case of here, it is the presence of endometrium outside the uterus. For example, in the around this peritoneal layer, which is causing this type of matchstick head colonies, matchstick head sign, or this type of in ovary, it produces this type of cyst, which is known as chocolate cyst. Fine. And this leads to this retroversion of the uterus, and this adnexal mass means around this uterusal area, it will be fixed in nature. Fine. So to diagnose this, we'll use this method, which is known as which is the laparoscopy. So with laparoscopy, we'll diagnose it, and we'll take up a sample, and we'll do histopathology examination, and we'll confirm it. So the gold standard investigation is the laparoscopy along with this histopathological examination. Fine. For medical management, the patient is complaining of pain. Okay, fine. So pain is because of this estrogen and progesterone cycle. So we'll give COC, combined oral contraceptive pills, which is having this progesterone action. Or else we can create a pseudo menopause state with danazole or GnRH agonist, Yeah, fine. Then we go for the surgical management to prevent if there is adhesions of this fallopian tubes causing this infertility. We'll remove the adhesions. And if the cyst, if it is more than 3 centimeter, this cyst is more than 6 centimeter, then we'll go for this laparoscopic cystectomy. Good canon. We'll go for this laparoscopic cystectomy. Fine. Next, about this PCOS. If you see about this PCOS, it is also known as Stein-Leventhal syndrome. And here there will be increase in androgens and decrease in sex hormone binding levels. Here usually, in a case of menstrual cycle, first there will be increase in FSH followed by increase in LH. Okay, so the follicle need to grow, then only it is able to go for ovulation and it can mature back. Fine. Whereas here the follicle is not growing. The follicle is not growing because of decreased FSH and increased LH. So the FSH to LH ratio here, it will be 1:2. So there will be decreased FSH and increased LH. So all of these follicles, it will remain in a very small size. Fine. So, and for diagnosing this condition, we'll use this criteria, which is known as Rotterdam's criteria. We studied in a case of bacterial vaginosis. What is the name of the criteria we'll use, guys? What is the name of the criteria you will use in a case of bacterial vaginosis? What's the criteria? Yeah, good Dr. Anar, good Dr. Gautam, good Dr. Kwanin, good Dr. Killer Mafia. It is what it is, this Amsler's criteria. Whereas in a case of PCOS, we'll use this Rotterdam criteria. So what is Rotterdam criteria? Well, in the case of Rotterdam criteria, there will be this ovulatory dysfunction, which includes this oligomenorrhea and amenorrhea, and hyperandrogenism, which includes this hirsutism, acne, and alopecia. And there is the feature of this polycystic ovaries on ultrasound. In ultrasound, you will be able to see there is a presence of central stroma. This is the differentiating features. There is a presence of this central stroma, producing this string of pills. And there will be more than 12 follicles. And all of these follicles, they are very small follicles. And these small follicles, it will be having a maximum volume. It should be always mostly less than 10 ml. Okay, so less than 10 ml of this ovarian volume, which is this type of small follicles which is forming with central stroma, is typical for this PCOS. And the female will be having this type of skin tags and blackening, which is known as acanthosis nigricans. Yeah, there is one more syndrome which is known as Hernias syndrome. That is also will be there. Here, if you see, we'll manage them based on it. For example, if a female who is just 15, 16, 17 years female, she is coming for her irregular periods. Her friends are having this regular periods, but she is having irregular periods. So to regularize her periods, we'll start her on OCP. Okay, so irregular periods में हम OCP देंगे. So based on the need, we'll treat them. Next, about this obesity. Obesity is mainly because of this insulin resistance. So obesity will give metformin. Okay, and for insulin resistance, we'll give metformin. Whereas if they come for hirsutism, we can start with combined oral contraceptive pills followed by this cyproterone acetate or followed by this additional progestins. Whereas in a case of infertility, in a case of PCOS, the preferred drug now it is this letrozole. It is the letrozole, and followed by which we can use this HMG and HCG for the ovulation induction. So these are the drugs we'll use. Fine. Why there is obese patients? This obese patients will be having, because of this insulin resistance. Because of this insulin resistance, they will be having this acanthosis nigricans. There will be more adipose tissue, and more adipose tissue will be exposed to this more insulin resistance and will be having this acanthosis nigricans along with the skin tags, guys. Fine. And hirsutism will use this cyproterone acetate, and for hirsutism scaling, for hirsutism will categorize based on a score which is known as Perryman Galway scoring. Okay, there is one more syndrome which is known as metabolic X syndrome. Okay, metabolic X syndrome. Yeah, all of the following metabolic disorders like PCOS will be there. In the case of type 1 diabetes mellitus, it will be having this acanthosis nigricans. Good, guys. Then PCOS, it is related to this metabolic X syndrome. Around here, if you see, there is this abdominal obesity which is more than 88 centimeter. And triglyceride level will be increased more than 150, and HDL will be, which is the good cholesterol, which will be less than 50, and BP will be more than 130 by 85, and there is this fasting blood glucose which is mostly impaired, which is 110 to 126. Okay, and here it also will be after 2 hours, it will be around 140 to 199. Just remember these things. Okay, yeah, everything will be high in the case of metabolic X except this HDL. HDL will be less. Remember, HDL will be less. Don't think that HDL also will be more. Okay, HDL will be less. Next, about this ovarian hyperstimulation syndrome, it looks like this PCOS, but if you see, there is no central stroma. No central stroma. Okay, so in the case of ovarian hyperstimulation syndrome, there will be no central stroma, and these are those patients who are being treated for the infertility, and because of this more beta HCG, what will happen? It will form this theca lutein cyst. It will form this theca lutein cyst, and it will present with these features of vomiting and hypotension. Vomiting and hypotension because of this third phase loss. So this is the classical feature of this ovarian hyperstimulation syndrome, and if it happens, then we need to intervene accordingly. Sometimes it can go under for this torsion, so we need to intervene immediately. Fine. Next, about this next condition, which is this genital TB. So we saw this kidney TB as well. Here we see this genital TB. So genital TB, it is also a secondary TB which spread via this hematogenous route. So most common site kya? It is the fallopian tube, and in fallopian tube maybe ampulla. Ampulla is the most common tube. So usually in a case of TB, we won't advise this investigation, which is this hysterosalpingography. Like in accidentally for infertility, we use this as one of the modality. So it is being done. So once this TB in which it is done, it will show this type of appearances. One is known as beaded appearance of this fallopian tube, and there will be this kind of appearance which is known as tobacco pouch. This kind of appearance which is known as tobacco pouch appearance. So there will be beaded appearance, there will be sperm head appearance, there will be tobacco pouch appearance, there will be other, for example, sometimes there can be a carnal block, but mainly these two, like beaded appearance and tobacco pouch, you should remembering of. And we know this is because of the TB, so we need to confirm it. We can either take their samples from during their menstrual bloods, or we can take some samples from the uterus. Okay, so we can do some endometrial biopsy, or we can do curettage and menstrual blood samplings. And finally, we will need to do IVF after clipping the both end of the tubes, and we need to provide ATT. Yeah, good guys, fine. And next about this urinary fistula. If you see about this urinary fistula, the most common cause of urinary fistula in India, it is what it is, this obstruction of the labor. The most common cause of urinary fistula in India, it is this obstruction of this labor. Fine. And in a case of urinary fistula, if you see, there is a continuous dribbling. It won't stop. Okay, urine won't stop. There is a continuous leaking. Okay, it is like it will be like from tap how it will drops, right? Like this, there will be a continuous dribbling of the urine in a case of vesico-vaginal fistula. Whereas in a case of stress urinary continence, it will be under stress. For example, if you are laughing loud, or if you are taking any stress, or if you are taking any weight, okay, or if you are having recurrent coughs, and in those moments, the bladder, like this will be like a bladder, and this will be the neck, and this neck will become hypermobile. And because of this mobility, once you cough, this will mobile, and there is spillage of this urine. There will be spillage of this urine because of this increased intra-abdominal pressure. Okay, so it is known as stress urinary incontinence. There will be involuntary leakage of this urine will be there. Fine. It is mainly because of this bladder neck descent or urethral hypermobility. And for this diagnosis, will tell the patient, will keep this tip in her urethra and will tell her to cough. And if this angle is less, that is normal. If the angle is more, will tell there is a bladder neck hypermobility, and this is because of this stress urinary incontinence, and will tell them to do exercises. Fine. The first line, it is what it is, the pelvic floor exercises. If it is not controlled by this, then we'll do this definitive management, which is the surgery. This surgery we can go for abdominal approach or vaginal approach. If it is abdominal approach, we'll do breast colpost suspension or Marchevit cords methods. If not, we can do some of these sling surgeries to prevent this bladder neck hypermobility, and we can treat this we can treat this stress urinary incontinence. This is the stress urinary incontinence. Fine. And next about this cervical cancer. So read about the staging of this cervical cancer. It is very much important, and its management, because that is the most common cause of post-menopausal bleeding in India. Okay. Then here also the patient will be having what? Bleeding, foul smelling discharge, and there what? And there will be having dyspareunia. Okay, dyspareunia. Okay, yeah. There will be a post-coital bleeding. Yeah, this bleeding is post-coital bleeding. After sexual intercourse, they will be having this bleeding. So these are the few features which will be seen in a case of CA cervix. In a case of CA cervix stage 1, it is limited to the cervix. 2A, it is this upper vagina. Okay, but it is less than 4 centimeter. 2B, it is the parametrial. It is the parametrial involved, but it is not involved yet involved this pelvic wall. Okay, in the stage 3A, it is this lower 1/3 of the vagina which is being involved, and 3B, remember it is a 3B, it is the most common stage, because when it involves this kidney or the ureter, it will cause this hydroureteronephrosis. It will cause this hydroureteronephrosis, and because of this hydroureteronephrosis, it will happen because of this parametrium involvement and this ureter involvement, and it is seen in a case of stage 3B, and it is the most common stage of presentation, and it is a late stage. Okay, itna yaad rakho. And C1, yeah, and C1, remember it is this lymph node. C1, it is the pelvic lymph node. C2, it is the para-aortic lymph node. C2, it is the para-aortic lymph node. Fine. And next 4A, it is the bladder and bowel involvement, and 4B, it is this distant metastasis, and 4B, it is the distant metastasis. Fine. And treatment, if you see for stage 1, mostly we do the conization, because it is just the cervix involvement, right? We do just conization or LEEP. Okay, we'll do. Then in a case of stage, in a case if the patient is not unable to follow up, then we can do hysterectomy. In the case of stage 1, 2 or 1B, 1, 2 or 1B, okay, there are like few differential stages. Then we can do radical hysterectomy or Wertham's hysterectomy. Whereas if there is after this stage 1B2 or 2A1, 2A2, we can do this Wertham's hysterectomy, and along with this, we need to start this intermittent radiotherapy and chemotherapy. Whereas in 2B, after 2B to 4A, we need to give this chemo radiation, and along with this brachytherapy. Okay, along with this brachytherapy, in chemotherapy we'll give this cisplatin. Okay, 4B mostly will give this palliative care along with this chemotherapy and radiotherapy. Okay, so see, there are 2 points which we use for this radiotherapy in the case of cervix. Okay, there is point A and point B. There is this point A and point B. If you see about this point A, it is 2 centimeter above and 2 centimeter lateral. It is 2 centimeter above and 2 centimeter lateral to this external os. Whereas point B, it is what? It is this 2 centimeter above. It is 2 centimeter above, but it is 5 centimeter. It is more 3 centimeter distant or 5 centimeter lateral to the external os. Okay. So usually in the case of point A, will give around 7,000 to 8,000 gray of radiations. Whereas in point B, will give around 2,000 to 4,000 centigrade of radiations. बस इतना याद रखना तुम. Okay. Then about this ovarian tumor. In ovarian tumor, mostly you need to diagnose it. Like they will give this clinical scenario. In this clinical scenario, you need to diagnose which of the following condition or which of the following type of ovarian tumor is this. Okay. If we see about this ovarian tumor, the staging of this ovarian tumor, it is mostly done on laparotomy. Like while doing surgery only, we'll do this staging. So it is known as surgical staging. Fine. And there are different types of ovarian tumor. There are this epithelial ovarian tumors. Okay, like serous adenoma and mucinous carcinoma, and there are some germ cell tumors and sex cord stromal tumors. Fine. This epithelial ovarian tumors, they are the most common tumors. Okay, and usually they are bilateral in nature. And this example, this serous adenoma will be having this concentric bodies, which is known as psammoma bodies. Okay, this is this serous adenoma. It is a serous adenoma. Fine. And next, if you see this mucinous cancer, it will be having this entire, or it will be having this huge amount of mucin, and it will be multiloculated, and it can result into a condition which is known as pseudomyxoma peritoneum. It can cause this pseudomyxoma peritoneum. Fine. And there is one more syndrome which is known as Brunner's syndrome, and this Brunner's syndrome, it is made up of this transitional cell, also known as Werthard inclusions. Okay. So next of this transitional cells, they are known as Werthard cell. So remember this Brunner's cell, there will be increased level of estrogen. So Brunner's cell, it will produce an increased level of estrogen. Fine. And these are the few epithelial tumors you need to know. The serous adenoma, the mucinous cancer, and the Brunner's cell, which produces this estrogen. Next, about this germ cell tumor, the most common one, it is the teratoma. And we know in the case of teratoma, there will be presence of this like multiple lineage of tissues. For example, hair will be there, there will be a tooth will be there, there will be a fat will be there, and there is a protuberance will be there, which is known as Rokitansky protuberance. Okay, yeah, if that will come, yeah. So if you see in a case of germ cell tumor, it will be mostly in a case of young woman. It will be mostly seen in a case of young woman, and in teratoma, it will be derived from this endoderm, mesoderm, and ectoderm. So it will be having this Rokitansky protuberance. Once you remove it, you will be able to see this hair grows over there. And it is most commonly seen during pregnancy also, and it can undergo torsion, and it can produce pain. And about this yolk sac tumor, you just remember, it will be increasing, it will be having this increased alpha fetoproteins. It will be having this increased alpha fetoproteins, and here you will be able to see this Schiller dual bodies. Here you will be able to see this Schiller dual bodies. Fine. And next, about this germinoma. And it is this most common germ cell malignancy. It is the most common germ cell malignancy. Whereas in males, it is the counterpart of this seminoma. It is the counterpart of the seminoma. Fine. And about this sex cord ovarian tumor, okay, you need to remember about this granulosa cell tumor. And in granulosa cell tumor, you will be able to see this coffee bean nuclei, and here it is also an estrogen producing. Okay, and it leads to this hyperplasia and carcinoma of the endometrium. So they will be asking which of the following ovarian tumor which can cause this estrogen production, and it can cause this endometrial hyperplasia. Your answer should be this granulosa cell tumor. And here you will be able to see these bodies which are known as Call-Exner bodies. They will be having this nuclear grooving which is known as Call-Exner bodies. Fine. And the marker you will use, it is the Inguinal. And here there will be arranged in a rosette formation. Fine. And if there is a presence of this ovarian fibroma along with this ascites and pleural effusion. So fibroma, ascites, and pleural effusion, it is known as mixed syndrome. So it is seen in a case of fibroma. Fine. And next, if there is virilization, breast atrophy, and along with this amenorrhea, it is seen in a case of Sertoli cell tumor. Okay, Sertoli leading cell tumor. Remember, it is seen in a case of virilization, breast atrophy, and amenorrhea. So all of this virilizing are this increased testosterone features. These are seen in a case of leading cell tumor. Fine. And the most common genital malignancy showing metastasis, it is what it is this CA endometrium. CA endometrium can come here and as a metastasis. And even the stomach cancer, they can come into this ovary, and if it come into this ovary, then there is an ovarian enlargement. And if there is an ovarian enlargement here, it will be a symmetrical ovarian enlargement. That will be what? There will be a symmetrical ovarian enlargement. And this type of tumors which is coming from this gastric glands or this breast, they are known as Krukenberg tumors. They are known as what? They are known as Krukenberg tumors. Fine. And now you got this HSG image where you will be able to see this filling defects inside the uterus. And if there is, if there is any, good guys, it is the abdominal mates. Good Dr. Anar, good Dr. Bhagav. Fine. If there is any filling defects inside the uterus, then like you will ask the history. And history, there is a history of abortion, and she has undergone dilatation and curettage. And after which she is experiencing a feature of amenorrhea, which is this secondary amenorrhea. So what is the disease you will think of, guys? What is the disease you will think of? You will think of this. This is which is lead to the formation of adhesions into the uterus, which is known as what? Which is known as Asherman syndrome. Asherman syndrome. Okay, the female with secondary amenorrhea and previous history of DNC, it is suggestive of this syndrome, which is known as what? Asherman syndrome. Yeah, good Dr. Gautam, good Dr. Bhargav. Yeah, good. So, okay, fine. And next, if you are able to see, good Dr. Anar. Yeah, good Dr. Parul. So next, if you see this HSG image, you need to differentiate whether this is septate uterus or a bicarnate uterus. See, if the septate uterus in HSG, if it is more than 4 centimeter, then it is a bicarnate uterus. If it is less than 4 centimeter, but now it is what? It is the septate uterus. But now we started using this more advanced modalities like MRI and 3D ultrasonography, so that we can detect is like easily or more advanced. Fine, whether it is bicarnate uterus or septate uterus. So remember, see this septate uterus, the septum is inside. So if our management of this septate uterus, we can go for this hysteroscopic lysis. Hysteroscopic lysis. Centimeter what? Yeah, it is, like see, the interdistance, there is two things. One is the centimeter, like what is the distance, the centimeter, or this angle. So if the centimeter, if it is more than 4 centimeter, and if the angle is more than 75 degrees, it is the bicarnate uterus. If it is less than 4 centimeter and the angle is less than 75 degrees, it is the septate uterus. Okay, these are the both two things. Okay, the means between these two, what is the length? See, I'll show you back. Okay, you got it, I guess, right? So see, this is the angle and this is the length. Okay, this is the angle and this is the length. Fine. And if it is septate uterus, we'll go for hysteroscopic septal lysis or septal ablations. Whereas in the case of bicarnate uterus, what we will do? We'll do in the case of bicarnate uterus, what is the name of this metroplasty? We'll go for this Strassmann metroplasty. Remember, it is known as Strassmann metroplasty. Okay. The final, the one part of this upstream means gynecology is going to complete. So endometrial carcinoma also you need to know the like motor staging. So if it is stage 1, there will be no myometrial involvement and there is no need of any treatment. Whereas if myometrium is half or 50% is being involved, okay, in such cases 1 to 2 vaginal irradiations, radiotherapy is being done. Whereas if it is more than half of it is involved, it is grade 3 and there will give this pelvic irradiations. Okay, and if it is stage 2, will give for whole abdominal irradiation, and in a case of stage 3 and 4, will go for this individualized chemotherapy and radiotherapy. Okay, so we'll remove this uterus, along with this will give both chemotherapy and radiotherapy. Will give for both chemotherapy and radiotherapy. So just mota yaad rakho, in the case of endometrial cancer, if it is stage 1, there are different stages. So initially, if it is no myometrial involvement, we don't need to treat. If it is less than one or half or 50% involvement, then we'll give for vaginal irradiation. If it is more than half, then it is pelvic irradiation. If it is stage 2, it is what? It is this whole abdominal irradiation. If it is stage 4 or later stages, what we'll do? We'll go for individualized chemotherapy. Okay, individualized chemotherapy and radiotherapy. But itna yaad rakhna, you need to, these are the things you need to remember from this gynecology part. Here we'll move on to this obstetrics part, and obstetrics part I guess we'll do it much faster than this. Okay, we'll finish up by usual time within 30 minutes. We'll finish it up. Okay, that is our motto.